Thanks, everybody, for coming back to join us for the afternoon session of the Awake Sleep Apnea meeting. I'm delighted to welcome back Dr. Shelley Burson. She's going to give us an overview of how sleep apnea is treated and the multiple approaches that it often takes to find the right combination of things that might help you live and function more fully. Dr. Burson?
Good afternoon. Are we working? Okay, good. So good afternoon, everyone. I hope you had an excellent lunch break and that you didn't have so many carbs that you'll fall asleep. There are many treatments for sleep apnea besides the ones that most people know, which is CPAP, and I'm going to go through that. And also some stumbling blocks, not just for patients, which is obviously why we're here, but I'm going to speak a little also from the provider point of view. We have some stumbling blocks going on as well. So, past, present, future. In the past, there was nothing other than an angry spouse and an elbow, maybe, to knock the spouse out of a snore. And then CPAP came along, and it was the Darth Vader mask, and that says I'd rather die prematurely than wear my CPAP mask. Thankfully, we've made a lot of progress since then. The problem is there are still a lot of people out there who look at CPAP and think about that picture and say, I'd rather die. So we need to educate those people. And it's really a matter of educating not only the patient, but also the bed partner that they are going to die if they don't treat it. So what we attempt to do as providers in the sleep medicine world is to customize a treatment. Before we said form and function, day one of medical school, blending those two things together on each individual patient, blending how the body works along with how it's shaped. So the reason for the beautiful picnic here is that when you have sleep apnea, you have to think way in advance of anybody else about the tools that you need in your picnic basket. Before you go out of town, you need to know, is there going to be a plug next to the bed? Is there going to be the right adapter if you're going out of town? Are you going to be on an airplane for a long time where you need a battery backup? Are you going to maybe just need your oral appliance and a little backup just in case? So it's mindful, and we need to think about it. It's very doable, but it's a lot of work, but it's doable, and we have to customize this. One size might fit most, but not all. We are shaped differently. I can't stress that point enough. Every person in this room who has sleep apnea has a little tweak on a tool or a device that might work for them, but it may not work for their neighbor. My plug for my ENT colleagues is that the airway begins in the nose. Air has to go through the nose, maybe the mouth, to get down to the lungs so they can do their job. Oxygen is life. Oxygen has to get in. We have the gamut of things to help treat sleep apnea. There is no such thing as a perfect pill. I know there are some pharma people out here. That's your job. Try to find one. Try to make one. There is currently no perfect pill that you can take that will restore and give you every single stage of sleep that you need to be healthy and well. Everything has a side effect. We're getting better, but that perfect pill does not exist. And there is a surgery that fixes all upper airway obstructive sleep apnea, and it's called a trach. Nobody wants a hole in their neck. Nobody wants a trach, but there is a surgical cure. The answer lies somewhere in between: pills, devices, surgery, and combos. Some of the diverse treatments that people do, and often I think Adam said that a lot of times you need a blend, you need more than one thing. There are several, I'm going to show some slides of a couple of these things a little later, but suffice it to say there are several ear, nose, and throat surgeries that start in the nose, going through the throat all the way down to the neck. Behavioral treatments, including weight loss and exercise. It was an old paradigm where people would just say, oh, just lose weight and you'll get rid of your sleep apnea. Not a thing. There are so many people who have sleep apnea who are not even overweight. So it might be a part of the journey, but not the whole thing. Devices, CPAP, APAP, BiPAP, there are oral appliances. Lots of sleep dentists are helping a lot of patients. Positioning apparatuses, Provent and Theravent, those are some nasal devices. A chin strap, sometimes that's all you need, is something to hold your mouth closed. Respitec is a device that holds the nasal valve open by sitting in your nose. And then there are medicines. Some people say, I just spritz my nose with a couple, decongestants or things, and I'm better. Allergy pills and allergy shots. There's a differentiation to be made between treatments for sleep apnea versus treatments for sleep. Some people have insomnia or other issues, behavioral reasons why they can't sleep. For those people, things like medications, meditation, cognitive behavioral therapy, sleep hygiene, allergy, and nutritional changes. That's not necessarily specific to sleep apnea, but a lot of people have comorbid sleep problems when they have sleep apnea. And this is an awesome treatment. I don't know if anybody here knows what this is. This is called a didgeridoo, and it's an instrument that actually is a treatment for sleep apnea, because what it does is it strengthens the pharyngeal muscles. So if you can increase the muscle tone in those muscles that are collapsing when you're asleep, maybe it helps keep your airway open. So this slide was just a potpourri, and there's nothing specific about a product that I endorse. It's just I went on the internet and I said, show me some pictures of some CPAP masks and devices. So the bottom line is there are a lot of them. The real story here is if you're a sleep apnea sufferer and you're not happy with your equipment, call your home care company, because they have access to all of these things, and you got to be a squeaky wheel and get them to give you the tools that might help you. Lots of things to try. There are some non-CPAP options. Again, there's nothing that's perfect. These are just some things. There's the Provent device that sits in the nose. You breathe in freely, and as you breathe out, there's an air column that holds open the back of the nose, and it works great for some people. There's an oral appliance there. There is a positioning pillow, like a sumo wrestler belt on the bottom. What's not on this slide is actually a tennis ball. That's the old-fashioned treatment, just putting a tennis ball in your nightshirt so you can't lie on your back. That's the Respitec on the bottom right. And then there are these pillar implants. There was a whole wave of time where there was a surgical implant device where if you stiffen the palate, it was thought that you would cut down on some of the snoring and maybe some of the mild apnea. It's really important that I show this slide as an ear, nose, and throat doctor, because these are some of the things that are completely being missed on a lot of patients who come to me. And they've already been, as some of your journeys have taken you, to other doctors' offices. And this is anatomy that's just fixable. So the top left, that's tonsils. Those are just in the way of your airway. That person is fixable surgically. The one below it, it's a nose that's loaded with polyps. It's all swollen. There is no way that a nasal mask is going to work on that patient. The middle one has there's a lesion on the back end of the uvula. If you don't look with the right tool, you're never going to find it. The middle one, those are vocal cord polyps. Air can get down through your nose and your oral cavity, hits that vocal cord. Those are flopping in the breeze. That person is going to have sleep apnea, needs a surgery. And then there's a big tongue. Some people are doing some tongue reductions to take down some of the volume of tissue. Separate slide here for a deviated septum, because people talk about this, and I don't know if they know exactly what it is, but if you see the S curve there on that septum, that left nostril is totally blocked. Air cannot get in there. Well, guess what? That's fixable. That's a surgery. My colleagues and I, we can fix those things. That's great. Turbinates that are big, we can fix them, shrink them down, allow the air to go in. Endoscopic sinus surgeries work great. And one of the little underreported side effects of having sinus surgery, or the balloon sinuplasty, opening up the sinuses, is that people say their sleep got better. We're not talking as an academy from the sleep people to the ENT people. We know we're helping sleep. So we should get that data together and get more people on the table if it's appropriate. New stuff is coming along. The FDA is approving things. This is a blend. This is a surgery and a device, a hypoglossal nerve stimulator. The early reports, if you are the appropriate candidate, it's a little strict right now, but there are some really happy patients. So, this is an exciting time to have new options. Stumbling blocks and minefields. Okay, so it's not always, now I'm going to, as a provider again, it's not always the doctor's fault. Sometimes it's a patient's fault. Sometimes a patient doesn't want to hear that maybe they have a problem. So, it's kind of difficult as a doctor. We're talking sometimes on deaf ears. And what I like to do is if I have that conversation with someone, I just document it. And I say, talked about it with the patient. I suspect the problem. Made myself available. I'm here for you. And then I hope that the lawyers won't come after me someday because the patient had a problem and, I thought they did. You can't force a patient to get treatment. So it is a stumbling block. It's an attitude, and we all need to work on that. So these are a list, and it's a potpourri, and I'm sure more of you are going to add to this. There are a lot of missed diagnosis opportunities by providers, and I cannot speak for anyone else, and I won't. And I love my colleagues, and we're busy, and we do what we do. And sometimes if a patient comes in for one reason, we fix that one reason. And I don't know how responsible we have to make ourselves to fix everything. But I still try my best to ask the right questions, like the stop bang on every patient, and try to find as much as I can. Limited access to testing. Sometimes there's a backup in the sleep labs for weeks, months. I don't know. It's hard to get testing. Insurance companies, sometimes they say no, even though we give them all kinds of data. Home care companies are inconsistent. They don't answer phone calls sometimes. Patients are frustrated. I don't know. I'm just throwing these out there. Patients' preferences aren't heard. Maybe they told somebody they wanted a different mask and they never got it. Bed partner. I'm not sleeping with you if you're wearing that Darth Vader thing. I mean, that happens too. Poor education, comorbid medical issues, financial considerations. And I know that this group has a program to help people who have those, and that's awesome. And more of us should give that number out. So the picture of the ears on the door, I mean, as a patient, you need to go into a place where you're being heard and listened to. And talk to your friends who are successful because they know they're charting a pathway that maybe we need to figure out who those providers are. My pet peeve, a lot of things what's being missed in a lot of patients who are on CPAP, or they've had an awesome surgery. You can drive a truck through their nose. What's missing? Allergies. Allergens in the bedroom that are contributing to nasal congestion. It could be the cat. It could be dust mites. It could be molds. It could be a laundry hamper that's got all the grass and pollen and stuff from outside. The other thing is, what are people eating that is adding to their inflammation? We talked about that before. Slow wave sleep, we talked about that. That's when the immune system repairs itself. If you're not having that slow wave sleep, your immune system is not repairing itself. There are other inflammatory conditions that just can act up at night. So you only get answers to questions you ask. So if you haven't been, ask an allergist. See if you can get to an allergist. And one more plug, clean your CPAP machines. A lot of hosing will have mold that starts growing in it if it's not cleaned. It's moist, and it is a breeding ground. I have seen people get terrible fungal sinusitis just from a dirty machine. So there are things you can do. We talked about REM before. I love it. We all need it. There are things that we're all doing that's robbing our REM, taking it away. And there are some medications that are doing that. Allergies do it, poor lifestyle choices, several medications that are very common. Alpha beta blockers, you can see the list here. And so be aware of what pills you're taking. And you might be safer not having so much REM, because if you're dangerous when you're in REM, maybe your doctor did you a favor by keeping you out of REM, but do you really want to be missing your dreams? I don't think so. So try to look up those lists. There are pharmacists and people on the internet. One little aside, a lot of people are on beta blockers, and just a pet peeve of mine too is a lot of beta blocker patients have insomnia as a side effect. It's very easy to treat if you add melatonin, 3 milligrams, a half an hour before you go to bed. Beta blockers undo the melatonin pathway, so a little supplement. A lot of other reasons that people have fatigue. We talked about this before, and I kind of use it as a hook in my office to see if people are tired. And undiagnosed obstructive sleep apnea, that's why we're here. But sometimes people have fatigue because they're not getting enough sleep, or they're eating the wrong foods, or having anemia makes you tired, depression, hypothyroidism, diabetes. My favorite, dehydration. If you're not drinking enough water, you will be tired. Heart disease, allergies, chronic fatigue, fibromyalgia, you talked about that, and medications. So this is my final slide here, and my message that I'd like to leave everybody with is that the secret to a good night of sleep is a good day awake. And that means being mindful about how you're spending your day and making choices that are going to help you have a good night's sleep. Exercise, nutrition, activity, all of that. And then sleep is unconscious, and it will just come on, and you will restore and repair. Thank you.
Thank you, Shelley. We have another panel I'm going to ask to join the stage, but first I'm going to rearrange these cards to put them in the order that they were expecting to speak. So while I'm doing that, if the 5 of you will come to the front. And this panel, as we've said, is going to focus on treatments and the way that these folks are both working with all of the options that Shelley just went through to treat and manage their sleep apnea, as well as start to get into the conversation and extend what we already started this morning with a description of some of the barriers to getting safe and effective treatment. So this panel, and I again won't use the names, includes a construction professional turned patient educator, a retired IT professional, a postal worker and community organizer, a Navy pilot, and a nonprofit grant writer. And they're going to share with us their experiences. Rick, get us started.
Hi, thank you, Kim. And again, thank you all for being here. I'll go briefly over my story very quickly. In 1982, I met this beautiful 19-year-old young lady who later, in 1983, became my wife. Well, the first night that we had spent together as man and woman, I wake up in the morning and there's this beautiful young lady sitting on the corner of the bed with this look of horror on her face. And I kind of woke up and looked at her going, geez, it wasn't that bad, was it? But she goes, no, she goes, I thought you were going to die. And I looked and I said, why? And she started telling me, I had stopped breathing, I was choking, I was snoring, I was thrashing around. I said, well, that's the way it was. Well, 10 years later, 1992, she comes home from the dentist with an article that she read in a magazine. She goes, here, they wrote a story about you. And there it was all about sleep apnea, and it was about me. So luckily, my primary care doctor at the time, when I went to see him, he hated his prescription pad. He didn't just like writing prescriptions for everything that was wrong. He wanted to find out what the root of the problem was and not just put a Band-Aid on it, but see if it could be treated. So he sent me to a new sleep clinic that had opened up in my town. It had just been open for a few months. So here I am going in and starting to learn about sleep apnea and the masks and, everything about it. Well, I was one of the very, very fortunate ones, and I consider myself very fortunate in the area of sleep apnea, was because the clinic was so new. The doctor we had, Dr. Nichols, never forget him, an outstanding doctor and outstanding staff there. They really talked to me. They let me know what was going on. They let me know what to expect in my sleep test and what was going to happen after that. They even showed me a VHS tape of what the CPAP machine was. And back then, CPAP machines were huge. My first machine was the size of a toaster oven with a separate humidifier that had a hose going from one to here, and another hose coming from here to my face, and never thought I could use it. And without their encouragement, without the education and training ahead of time, I wouldn't have been able to use it. Well, subsequently had my sleep study. The first night of sleep, 36 years old, was the best night's sleep I'd ever had in my whole life. Absolutely woke up, and I was amazed at what a good night's sleep felt. Well, again, as I was lucky, I ended up becoming a case study for this sleep clinic because I was the youngest person they had ever seen with sleep apnea and the most severe case they had ever seen at that time. So I actually had to go back 4 times before my pressure ended up at just about 17, where they found it. Well, as I went through, it was fine. It did well. I felt much better. It worked from the very first night I used it. And I can go on with all the great things that happened, not falling asleep when I was driving anymore, not eating so many chocolate shakes and French fries to buy through drive-thrus to try to keep myself awake while I was driving. But one of the most amazing things that had happened, working with the American Sleep Apnea Association, talking about some of the things, a few years ago I was talking with my youngest daughter about it. And she goes to me, "Pop, don't you know that all of us remember the day that you started using your CPAP machine?" And I joked, and I said, "Why? Because the house was quieter?" She goes, "No, Pop, because the house was nicer." And I said, "What do you mean?" It just kind of caught me. I said, "What do you mean?" She goes, "Pop, when you started using your machine," of course my children were very young at the time, she goes, "you were a changed person." She goes, "You didn't come home, tired and grumpy and yelling at us and falling asleep on the couch and, all the things that you did. Now you were spending time with us. You had patience. You were reading to us. You were riding bikes with us. You were playing with us." She goes, "The CPAP machine didn't change only your life. It changed all of our lives." And which I thought was very, very powerful because I never realized what effect I had on other people. I was really, when I look back upon that, I was a pretty crappy person. But sleep deprivation will do that to you. It's not that I want it to be that way. And so as we moved on, I was very fortunate to meet and to work with the Sleep Apnea Association. I've done many programs over the years to any groups that want to hear what we have to say about sleep apnea, to educate about sleep apnea. And the reason for that is, and I think where society is lacking, where the medical profession is lacking, where the insurance companies are lacking, are the importance they put on sleep. Sleep is way down on the bottom of the list, okay? We all know, as people who've been involved in it, sleep is one of the 3 pillars of life. There's sleep, nutrition, and exercise. Without good nutrition, you're going to be sick. Without exercise, we know what happens. Well, without good sleep, you're a crappy person, besides not feeling well. And so the questions that I have to ask, to the people that are out here, and we appreciate everybody being here, is why is questions about sleep not part of a yearly physical examination? Why don't our doctors simply ask that? What's going on? Why do these days, and again, I consider myself very fortunate because I was part of the beginning part of it, where when I went through my whole process at the sleep clinic, and then when my DME brought me my machine, okay, they taught me how to use it. They sat down with me. This is how you put it on. These are the different masks. This is what you do. This is what to expect. Nowadays, DMEs go out. "Oh, you need a machine?" Either they mail it to you or they drop it off. "Here it is. Here's how you turn it on. See you later." Okay, because one of the biggest complaints that I've heard at a lot of programs that I use is I don't use my machine. I went home to try to use it, didn't like it, woke me up, dried me out. This didn't work, so I just put it in the closet. Okay, we need to have a process, and a process needs to be established. First of all, find out about sleep. The medical doctors need to know, the primary physicians, how important the sleep is. Okay, second of all, we need, when our DMEs are coming in, to explain and to teach people, how to use them. Okay, and to realize. And the third thing is, don't have doctor panels that are someplace over there that are not even sleep physicians decide what's best for a sleep apnea patient. Okay, and I will end with what happened to me quickly with an insurance company about 5 years ago, and I'd already been on sleep apnea for over 20 years, and my new machine came in, my provider billed the insurance company and then said it was denied. And so I went back, asked why it was denied. They said because the panel of doctors, which were established back then, said I didn't meet the criteria, so I put an appeal. It was denied. We finally went back and forth, and I was literally told that the panels of doctors are much more intelligent than I am, so I need to stop arguing about it. Finally, I talked to the woman on the phone from my insurance company. I said, have you ever looked at my file? And they said, I don't need to. Our doctors told us what you need. I said, take a look at my file. She put me on hold. 5 minutes later, she came back and approved my machine. So we do need to fight these things and to make it easier for patients to have access, education on that, and then access on how to use it, the training, and to get that part of the profession a lot more into what we're doing with sleep. Thank you. That's all. Southern California. Yeah, unfortunately.
Paul Bloomstein is our local from Annandale, Virginia. Paul, share your story with us, please.
Okay, I was first diagnosed with sleep apnea a little over 15 years ago. I must have had it much longer because I've always been a heavy snorer, and I think it kept getting worse, and I finally realized that I needed medical attention when I woke up and realized I'd been sitting at a traffic light for a long time asleep. And I'm sure glad when I fell asleep it was at a traffic light and not while I was driving. Went to my primary care physician. He said, it's a possibility you have sleep apnea. I'm going to send you to an ENT. He'll probably have a study done, which is exactly what happened. And I was diagnosed and given a CPAP machine, and that made a world of difference in my life because I no longer had to worry about falling asleep in dangerous places or places are embarrassing or maybe even causing me to lose my job if I fell asleep at work. Initially, my sleep apnea was diagnosed as moderate, but I monitor it with a program called Sleepyhead, and that has shown that my apnea is still getting more and more severe over time, and that's become a concern for me. I'm using an auto CPAP. The maximum pressure that you can set it to, I set it myself, by the way, is 20 centimeters of water, and I hit that top value sometimes. Doing some research, I found that the highest machines I can get are automatic BiPAPs, but that still only goes up to 22. So I'll be seeing my ENT in about a month to discuss this with him. I'm sure he's going to move me to an auto BiPAP, set it to the maximum, and I just hope it doesn't go any higher because then I may need surgery, and that, of course, is a concern. Another problem that I've been having is traveling because you got to drag the CPAP along with your other luggage. You got to make sure you're sleeping in a place that has an outlet, and I always carry an extension cord just in case. And the biggest problem I'm having post-diagnosis is that in the mornings, sometime mid-morning, most days, I start feeling tired. That's known as, the doctor said, as excessive daytime sleepiness or EDS. So what I do is either one of two things. I either take a power nap between 1 and 2 hours, and I'm not always in a position to do that, of course. In that case, I take either 150 milligrams Nuvigil, which is the same medication that's usually used for narcolepsy, or one of the narcolepsy medications. However, Nuvigil has a side effect, and that is if you take it regularly, you start getting insomnia. So what I do to try to minimize that is not take the Nuvigil if I don't have to, and on days that I have to, make a judgment call whether I could get away with half a pill instead of taking a full pill. Okay, and one more item I'd like to note is I do use my mask every night without fail, no matter where I am. However, when I take my power naps, I don't use the mask. The interesting thing is I don't snore when I take the power naps, and I think it's what's happening is the pressure from the CPAP is compressing the tissues in my throat area, and the 1 or 2 hours of the nap isn't enough to loosen it up again. So that's kind of nice. And the reason I don't use the mask is more, I know it's better to use it, is more for psychological reasons. It gives me a break from using the mask, because I use a full face mask, and it's kind of like feeling an octopus is clung to my face, and I just want to be able to sleep once in a while without that feeling. Thank you.
Thank you, Paul. Next, Celeste James from St. Albans, New York.
Hi, everyone. Good afternoon. I think I'll start with my background. I was diagnosed in 2015 with sleep apnea as a result of having the NYU School of Medicine come into a health fair, this huge health fair that I was hosting at my church. And because I was the host of this big event, I wanted everyone to feel comfortable speaking with the health professionals and the physicians and, everyone who had something at their table that you needed to participate in. I went in and did that thing. So I had my blood pressure checked and my eyes checked and all these wonderful things happening. And the NYU School of Medicine was asking several questions about a variety of sleep difficulties. And so I sat and answered some questions and made sure that everyone else knew that these were not personal questions. There was nothing here that was going to hurt you. And I sat and answered the questions. And someone pretty quickly said to me, looking at my responses, do you mind if we follow up with you? And I said, sure. Look, everybody, it's not going to hurt you. Sure, they can follow up with me. And they came back to me in the event and said, do you mind if we get in touch with you about, a further type of study connected to whether or not you might have sleep apnea? So I said, sure. Look, everybody, they're going to follow up with me. Never even occurred to me. It was only for other people, honestly, for other people that I did this. Because at that point, I did not know sleep apnea. I had never heard the term sleep apnea. I didn't know anyone. I know now that I know people that had sleep apnea. I didn't know what this was about at all. So, of course, I said, sure, come on. So they did, in fact, get in touch with me very quickly after that, and asked me follow-up questions and made it clear that there might be something there. Did I mind if we did a home study? Sure, we can do a home study. So they came, put the monitors on my wrist. You guys know how this goes. And very shortly after that, it was clear that I did, in fact, have sleep apnea. And we did that study where they attach all the electrodes. You know, the one where you don't get any sleep that night? Yes, we did that. And I was able to get a machine into my home. Now, I have had health insurance, like I said. I worked for the U.S. Postal Service for 31 years. I retired as a customer relations coordinator. So I stood between the Postal Service and angry customers and local elected officials and community board members and the borough president's office. I serve my community in a variety of ways. I also sit on my local community board, and I have been a producer and director at Queens Public Television, so I get to have an active voice in what my community receives. But I try to be as active in what my community needs as I can be. And so this was a great opportunity for me to experience this thing and to be able to talk about these things. Because like I said, I didn't know anything about how sleep deprivation was going to affect my life and everyone else's. I had no idea about how long I have been experiencing sleep deprivation issues until I got involved in this progress. Because when I got my machine, this was through the NYU School of Medicine and their affiliates. But I can tell you that when I got my machine, there was some sort of difficulty between the prescription number that the machine was at and what I actually received, because this was not something that I could control. This was something that was programmed elsewhere. And so when I got the machine and I was shown how to use it, my prescription was stronger than what the doctor had spoken to me about. So when I got the machine at home, I was thinking at first that I just needed to get used to what the pressure was. But truthfully, it was so strong that it was keeping me from being able to use it properly. I could not sleep because the air that was coming at me was blowing up my nose and into my face so strong that I was gagging. I could not sleep. When I tried to get back in touch with my health professional at that point to let them know that I can't function this way because I'm getting no rest. And I was told, well, you have to use the machine at least 6 hours a night in order to be able to keep the machine. Otherwise, they're going to take it away from you, and you may not get another one. So I'm like, what? So I can't get any sleep because the wind is coming at me like a wind tunnel. And what do we do then? Because it could only be changed at the point of the prescription. So the doctor had to actually change it. And then someone else had to program it remotely from wherever they were. So I had no control over it whatsoever. And even though I made it plain and clear that I was having a problem and that this was, in fact, keeping me from sleep. I wasn't even getting the sleep that I was getting before I had the machine. Now I'm not sleeping at all. But no one was responsive to me. And there wasn't anywhere for me to go because these were the people to respond to that problem. But it was taking so long that I was miserable. Now I wasn't even getting the few hours of sleep that I had been getting. And I had found at the last time that Mr. Amdur and I had met that there was a certain amount of weight gain that I didn't understand that came with this malady. And so I changed the way I ate. I was working with a nutritionist. As a matter of fact, my initial nutritionist is here. And so we talked about what was important to have in my diet and what was working well with the diabetes and these various things that I needed to do. That I did. But even if you do all the things you need to do outside of yourself, you're exercising, you're allocating a certain amount of time to sleep. If you're not actually getting good sleep, none of it is going to matter. So I'm eating the right things, I'm exercising during the day, and I'm laying down to sleep dreading going to sleep because I know that for the next 6 hours, I'm going to have this wind gagging me, and then I had to get up in the morning and try it all again. And so I say all of this to say, even if the other parts are in place, I can tell you that I remember driving along and just trying to get home because I was exhausted, because I knew that once I got home, I'd be okay. But I would get all the way home and park in front of my home and go to sleep in the car and have my neighbors knocking on the window because they were afraid that there was something wrong with me. I remember driving parkways alone at night and being so tired that I had to pull over. The only night, honestly, I was afraid that I was going to die. It was snowing like mad. I was going to sleep. And I couldn't stop. So as soon as I could, I pulled over onto the shoulder. And I said, if I could just get 15 minutes, if I could just get a power nap in, I'll be okay. I'll be all right to drive. And as soon as I pulled over, a policeman pulled over and knocked on my window. And he told me I could not stay there. And I said, I've got to rest. I'm not going to make it home. I'm going to kill myself with somebody else. I was on an elevated roadway. I was afraid I was going to go over the edge because when I was dozing, I felt myself swerving. That was the only night I was actually afraid I was going to die or kill someone else. But he would not give me 15 minutes. I know he had his rules to follow. But I was really afraid that night that I was not going to make it home. Because as soon as I got away from him and I was able to get over someplace else, I had to close my eyes. I needed to get some rest. And I certainly wasn't getting it. And it took a really long time. It took longer than it should have because it was not just my life. The same way Our lives are not our own. We are involved with a lot of people, and what we do affects the lives of other people. I could have killed someone at any time. I was tired. I was taking no medications except for my diabetes. I manage my treatment by making sure that I am active during the day. My mind is always active, and so I have difficulty getting to sleep in the first place. I am recently retired from the U.S. Postal Service, which was not my first job, but I worked for them for 31 years. But I'm still active in my community. I'm active in my church. I'm active in local politics. I have 2 small businesses. I'm busy all the time. My mind is always at work. But I make sure that I am doing meditative talk downs in the evening. I pray at night, but truthfully, when I pray, it just sends my mind into all sorts of other things, so that doesn't calm me down enough to be able to rest. But I do meditative talk downs, which you can find online. And I do exercise. I have lost a few pounds. When I get up in the morning, I try to do a few minutes of cardio to raise my heart rate. I do a little kickboxing, just a little, because, I don't want to have to hurt nobody. But
But he's going to mess with you now.
I appreciate that. But I do try to manage what goes on with me without taking painkillers and other things, because summer before last, I was thrown by a horse. And since then, I have some issues that make it difficult for me to sleep. I can't rest in one position for too long, because then that begins to hurt. So I travel with my CPAP machine and a heating blanket, which also plugs in near the bed, But because I'm not taking anything for pain, every few minutes I've got to toss, I've got to turn. Otherwise, I'm having difficulty resting. But once I get to sleep, I've got 6 hours coming. But it takes a little while. It takes a little while. But I thank you so very much for your interest and for your participation in my health. Thank you.
Thank you, Celeste. John from Virginia Beach, tell us about your experience.
Well, first of all, thank you very much for having me here. I believe in fact, I'm certain I've had sleep apnea probably most of my life. I had issues falling asleep in high school. I used to dread chemistry class. I am the guy who was a naval aviator, and it really became serious for me, and I didn't realize that I'd had sleep apnea, but I had to start to try to deal with the symptoms when I was flying and we were deployed, and there came times when I would just be so tired that I'd be falling asleep in the airplane. And so I went to the flight surgeon, and I had one assigned to my squadron, and they would give us basically anything we asked for. So I could get stimulants, I guess it was speed, and would do that with regularity from them throughout my flying career. I then also would get from them Ambien when we weren't deployed. You couldn't get Ambien when you're on the ship, but you could take it when you were not actively deployed. So I combated the symptoms of that of sleep apnea for a long time like that. I had the unique experience of being sent to Iraq for 14 months with the Army, and on the way over there, the standard open your mouth and let me see the back of your throat, and the guy goes, "Damn," and I said, "What?" He said, "Do you snore?" I said, "Yes, I've been told that I do." And he says, "You need to get checked for sleep apnea." I did after I got back, and I had it, but as I was still deployable, I got the oral device. And the oral device was really pretty effective to prevent snoring. I still have it. It's 10 years old. I'd like to figure out how to get a new one, but that's an insurance issue. But it didn't really solve the sleep issues because I still was tired. And in fact, I told during the interview, it was a trauma for me, but I was with a 4-star admiral. We were doing this VTC with Chief of Naval Operations and everybody in the world. So I'm sitting next to the admiral on this VTC, and I fall asleep and snort badly in the middle of this meeting, and nobody was happy with that. So I walked out there and said, I got to do something. And I knew I had it, so I went back, got another sleep study, and they gave me a CPAP. And I really liked the CPAP, but my partner did not. And so that lasted for not a long time. I felt good using it, but the issues, she would just say, no, you don't need that. You need to lose weight. This is going to ruin our relationship. And so all those things, I stopped using it. And I went back to the oral device. And in fact, the reason that I got invited to this meeting was I can't use the oral device anymore because my dentist put a crown on and it doesn't fit. So I'm not doing any treatment right now, and I feel it. I feel the results, and so I'm going to endeavor to go find that CPAP. Because I've moved a couple times, it's put away somewhere. But I want to start using it. I hear the stories here. I hear about some of the things. When I came back from Iraq, I had a massive AFib attack of hypertension. All of the things that I think the medical community is treating either via medication or other means that are really just outcomes of sleep apnea. Because I know when I use that machine and it's working and it fits, it's really helpful. But the final thing I'll say, not even with the machine, I got it. Nobody ever showed me how to use it. I didn't know how to fit the mask. I don't know what the buttons mean, and I'm kind of a buttons guy. So what's this do? If the community out there, if that's one thing you could take away, people need to be trained on how to use those things. I think there's a technique. My mask sometimes it leaks, and I try to fix it on my own. But when it's working, I feel good. Thank you very much.
Thank you, John. And last but not least, Erin Taylor from Colorado Springs.
Good afternoon, everyone. I'd like to thank the American Sleep Apnea Association for inviting me here today and allowing me to tell my story. After the birth of my first child in 2010, I had gestational diabetes with that pregnancy. And after that, I started to notice a lot of disparate health outcomes that I thought were unrelated. I was having chronic pain and spasming in my back. I was extremely fatigued, which I chalked up to being up with a baby all the time. I was starting to have memory and concentration problems at work. I was getting ill all the time. Every time a cold or flu would go through the community, I would get it. I was snoring extremely badly, which I had never done before. And I didn't really know that all of these things could be connected and have a root cause. Several years later, my parents were both diagnosed with sleep apnea. One has obstructive and one has central sleep apnea. But even then, I didn't quite put together that a lot of the things I was suffering from might have some common causality in sleep apnea. Finally, so many of these symptoms got so bad in the summer of 2017, and my parents at that point had talked to me a lot about sleep apnea and about using CPAP machines. So I decided to go in and talk to my doctor about it. And I have a wonderful primary care physician, and as soon as I mentioned it, she got me a survey, and I scored very high on the types of symptoms that might indicate I had sleep apnea. So she recommended a sleep study. And it took me about 6 weeks to get into a sleep center. So that was sort of the first barrier I faced, is that I wanted to get a resolution immediately. And it was hard to get into that first sleep study because they were just overbooked with people needing solutions to sleep problems. But I had my sleep study. I was diagnosed with severe sleep apnea. I stopped breathing about 50 times an hour, the longest time for 40 seconds. And So they actually put a CPAP on me halfway through the night and said, try sleeping with this and see if it helps. And it did. I felt really remarkable after using the CPAP for several hours. I thought I got great sleep. So I was really excited to go home and start using my CPAP any day. And it took a little bit longer than that. I didn't, my sleep study was October 6th, and I think I finally got my CPAP on November 8th. So it was a month of knowing that there was a solution out there for me and knowing that I could be getting better sleep and not having it yet. And I think there had been some confusion about whether I should be going in for a second study to determine the level of pressure I needed, or whether it was just slow processing with the insurance company. But that was definitely a barrier to me getting started. Once I started using my CPAP machine, I really had a lot of success with it. I was very lucky that they got the pressure setting correct right off the bat. I didn't have too much trouble with the masks or any of the rest of it. The biggest problem I had is, I guess, getting a good seal with the mask, and I use a full face mask. And when I first started using the CPAP, I was having a lot of trouble with getting bursts of air up in my face and in my eyes when the mask slipped when I moved positions at night. And so I ended up, I never could quite get the hang of adjusting the mask perfectly. Some nights it worked really well, and other nights it was just blasting me in the face with air a lot. And when my CPAP arrived, it was mailed to me. I never had any contact whatsoever with anybody from the medical device company. So I never, I had instructions on how to put it on, things I could read, but I never had anyone showing me how to adjust the straps or, talking to me about these things. So I agree with many of the other panelists. That's an area that could use a lot of help, is sort of hands-on instruction on how to really use the CPAP appropriately. I do use my CPAP 7 nights a week for the entire time that I sleep. And one of the things that really helped me adapt to using the CPAP right away was an app that actually came with the CPAP device, and their literature they included told me about it. And this app, it tracks how long I use the CPAP every night, how many apneas I have, how many times I take the mask on and off, and and then how good the mask seal is. And it gives me a score. So I can look at that. I can get immediate feedback every night. I can look at patterns over time. And I've found that tremendously helpful. Getting that immediate feedback is so useful to me, because it just lets me know that, yes, it is being effective. Oh, good, I only had 2 apneas last night. Oh, my mask seal wasn't great then, and I tightened these straps one way. Maybe I'll try doing something different the next time. So having that immediate feedback was incredibly helpful, and talking to a lot of the other patients here who didn't have that app to give them feedback, I think it could help a lot of people to do that. So that was really most of my feedback. The only other thing I would really suggest is the process with the insurance could be a lot easier and more helpful. I really have been working with the supplies that I first got with my CPAP, because it's very expensive to buy the replacement masks and replacement hoses, and they my insurance won't cover them until I've met my deductible. So those are basically entirely out-of-pocket expenses for me. The other problem I'm running into is that my insurance does not want to pay for my sleep study, and I'm still in the process of appealing that. They're trying to charge me the full amount for the sleep study. And that was supposed to be, sort of pre-approved between the company and the insurance and the sleep center, but it didn't. Something did not get approved correctly, so I've been battling with that. So I would say, those are some areas that could use some attention, and maybe some changes in policies or procedures. But I want to thank you all for coming and listening to our stories, and thank you for being here.
Thank you, Erin, and to all of the panel for your courage and for sharing the the successes and the challenges that you've encountered over time and still face ahead. I'll invite you to come back to your seats. I know we talked a little bit about whether to keep you up there, but let's integrate you back into the room so we can focus all our attention this direction. And while they're moving back to their seats, let's do a little bit of poll. So, Eric, if we could do poll number 8. Get a sense of folks in the room and watching via the webcast. And I think we had 400 some people watching on Facebook in the morning session. I don't know how many might have come back after they had their lunch or breakfast, depending on which coast they were on. But let us know which of the following have helped treat your sleep apnea. And for this one, you can check all that apply. And these are just the airway-related treatments. We'll have another polling question about medications you might be using and also supportive therapies. So this group, and I'll just say a little bit about the survey results. We've talked a bit about the survey all the way through. We had 2 different survey populations, one that was older with more lived experience, longer treated, and that group had about 88% of them were using CPAP on average 7 nights a week and on average 6 to 8 hours a night. The other group that we recruited with the help of Evidation, a technology platform that was younger, a little less severely affected, a little less treated in terms of their sleep apnea, was only using CPAP about 46% of the time, I think was the figure. So really interesting to see the differences depending on how you come about the survey. And in this room, it seems like we're somewhere in between that, in this room and on the web. We also saw a lot more people who had had an oral appliance in the past than were using it at present. And folks were only using their oral appliance on average 3 nights a week and for 4 to 6 hours a night. So just interesting data to kind of support what we heard from the panel and also what we're seeing here. So CPAP stories in the room, on the panel already this morning, just now, through the survey and the open field comments. Boy, people love the benefit that they get from the CPAP when it's working well, or the APAP or the BiPAP, airway pressure when it's working well. But there are a lot of challenges with getting that positive benefit and effect. Phyllis, coming from a caregiver perspective.
Right, so I wanted to speak because I haven't heard the caregiver's perspective at all today. And when my husband first got his CPAP, which I was thrilled about because I was well aware of the sleep issues he was having, and I was quite frightened and did not want to be a widow at such an early age. His CPAP was so disturbing that I suddenly developed sleep issues. And I don't mean that in a light manner. And I went on to communities to find out what other spouses were doing. And I was stunned by the amount of negativity towards the caregiver. That how dare you? I mean, I didn't put a comment. I was reading comments. How dare you? Your spouse finally is getting some sleep and you're complaining. And what they didn't understand was that I wasn't getting any sleep now. And what he shared this morning was that he actually went out and bought me these industrial-grade earmuffs. So now I could only sleep on my back. I couldn't roll over. And we used to make a joke that was Darth Vader and Princess Leia sleeping at night. And, we would tell our friends and they joke, but it wasn't a joking matter. So I just want to point out to that as we have this discussion that there is a serious consequence often for the caregiver with the CPAP.
Well, we heard a lot in the survey about, okay, we're sleeping in separate rooms now or separate ends of the house maybe to accommodate that. I see Teresa's got her hand up.
I was a sleep technician for many years, and what you've just described is not totally rare, but it does happen. And my theory is you didn't like it when he was snoring. I'm sure that kept you awake as well. But now your job is over. You were used to nudging him to wake him up. And sometimes I do believe that because your job has finished now, it's left you a little bit uneasy about who's sleeping next to you. Is he going to breathe? Is this really going to work? And I sense that anxiety. I did sense that for many patients' spouses. But there was one more thing that I wanted to talk about. I'm not a sleep tech anymore, but I did it since the 70s. And the one thing that I don't think that people have thought about is the stigma, and maybe the stigma of having this disorder has diminished because it's more commonplace now to have a CPAP. However, the stigma of wearing it and having to deal with it and has not really left completely. I think that some people are still a little bit embarrassed. But the stigma of, geez, he's so lazy, he won't do anything. He won't get up and play with the kids. When somebody said about that the house was nicer, that, the person has probably just, gone through a lot. A lot of the patients that I saw went through a lot of getting fired at work because they were falling asleep. They were not performing like they should. So there's so many other issues besides the actual health. So this stigma, oh, he's lazy, he's a rotten father, he won't get up and play with kids. There's so many other things that go along with this because it's sort of an invisible thing. If you think about it, you can't look at somebody and say, oh, sleep apnea, So anyway, I just wanted to say that.
Yeah, I think your point about the stigma is also a barrier to diagnosis for some people. That the idea that, oh my gosh, if I do have sleep apnea, I'll have to wear one of those horrible masks, keep people from doing that. I had a conversation with somebody yesterday who said that very thing. And so all of the health consequences we've heard about may layer on just out of fear of the way to go about primary treatment. Will, you wanted to build on that.
I was looking at the list, and I thought, I have had every one of those. And unlike a lot of people, I started at the bottom, tonsillectomy, and then went to deviated septum. Then I had a surgery. Then I thought, there's no way I'm going to do a CPAP, so I went with the oral appliance. And eventually, now I'm a CPAP user and a very adherent one. And because I think, everyone knows you'll get sick if you don't take care of it. My father had all the classic symptoms, and I realized that, so that's why I do it. One of the things that I've just wanted to mention is the frustration with the pace of innovation in the world. Because if you really think about it, the CPAP machine is quite old, probably 20, 25 years old. And the APAPs and that kind of stuff are a refinement of that. But you don't see any kind of new things coming out. And I just refuse to believe that there aren't answers, that can come from different sources. And so I don't know what's driven the innovation out. I think it's incrementalism, making something smaller and faster and lighter works to a certain point. But as the survey results show, that you don't get perfect results. People are still tired even if they use PAP machines, and they're still tired even if they use the oral appliances. So the status of the treatment options today, I think, are stagnated for some reason, and I get frustrated with it, and I talk to a lot of patients, and they'd like other kinds of alternatives to come along. And so far, it's been a very incremental thing. We had the tongue stimulation come along, and of course that had to cost a ton of money, to be able to get that through. So, for what it's worth, I don't know what it's going to take to get more things in the pipeline, but I'm hopeful. And while I'm hopeful, I'm still wearing my CPAP machine. Thank you.
Thanks, Will. Somebody else had their hand up, I think.
Hello, I had both an observation and a question. The observation is that on that list, there's not an alternative for what might broadly be called behavioral therapy, or at least in my particular case, the obstructive apneas are more frequent when I'm supine versus on my side. So one of the therapies is to try to sleep more on my side. And I'm not unique in that, it's actually common. So that could be added as another answer to the question, positional sleeping. But then my question, which is, I get the impression both from my own doctors and this meeting that that generally the objective should be to have CPAP treatment, that you would be healthier if you had CPAP treatment. If you just tried hard enough, you'd be successful. And I'm wondering whether it is the case that truly you just try hard enough and you'll succeed. The data that I've read suggests a large fraction, perhaps 50% of patients are non-compliant with CPAP. And I'm wondering, so the question format of it would be, what is understood about the non-compliance, beyond that if you have more education and a less noisy device and so on, maybe you'll be more compliant. Is there any insight as to whether there might be a class of patients who are non-compliant because the therapy is inappropriate for them?
Carl, can I tap your knowledge of that literature?
Yeah, you raise a great question about how do we improve. You raise a great question about how do we improve CPAP adherence, and I think historically what we've done is we've looked at the patient and what they could do differently. I think we also need to look at the healthcare system and how do we provide the initial education, the initial support. And I think the literature is pretty clear. If we provide that good support early on in those first several days to help them troubleshoot any problems they have and overcome any problems, that can be really helpful. So we've done the CPAP adherence interventions are pretty clear that we can improve adherence by a couple hours per night if we can provide that kind of education. I think one of the most important things too is making sure that people understand what the benefits are. Oftentimes it's an experience of what are the benefits of therapy versus the cons of therapy. So helping people get to use a good CPAP trial, I think, is really important.
Aaron, I appreciated your comments on the panel about how you adjusted to using the CPAP, and I wonder if there's anybody else who could offer some suggestions about how to be more successful and not to put the blame on the patient if it doesn't work out. Maybe it's not the right treatment, but to maybe give it the best shot you can. Rick, I know you're a big avenger, right?
I love
avenger.
CPAP. As I said, I got diagnosed in '92, and I've used my CPAP pretty much almost every day since then, and through a variety of machines, variety of masks, and all of that. But in the beginning, Teresa, you were talking about the stigma of it and what people think. And when I looked at that first VHS tape, when the doctor showed it to me in his office, remember this was in the early 90s, and he came back in, and I was sitting there with my wife at the time, and we looked at it, he comes back in, he said, "What do you think?" And I looked at him word for word, said, "What are you, effing nuts if you think I'm going to wear that?" And he kind of looked, he smiled, he said, "Yeah, I get that a lot." But how we put it in perspective, and this is, again, part of the education that Carl was talking about, getting used to and having people trained, what you were talking about up there. And he had said to me, you have to look at it. The CPAP treatment is actually very simple treatment when you break it down. People who wear glasses in here, what do you do first thing in the morning? You get up and you put your glasses on. At the end of the day, when you're done, you take them off. Your treatment is done for your eyes for the day. CPAP is exactly the same way. You lay down. I have my mask hanging on a hook right next to the bed. I lay down, I put my mask on, I go to sleep, I take it off. My treatment's done for the day. And breaking it down into simple terms really, really helped. That it was just a simple part of the treatment. It was a few hours a day. He said, you don't have to carry your machine around with you all day. You don't have to hold it over your shoulder. You don't have to wear your mask on, you know. And I mean, I love it. It's been great for me. As you heard, it was great for my family. One of my wife's now favorite expressions before bed is "put your mask on," you know. So she makes sure that I have it on. But when we can get it down, you get the education when they know how helpful it is, when they know how simple the treatment is. Then we have to remember that CPAP treatment, when used properly, is almost 100% effective with no side effects. And when we can realize that and start digesting that information, it helps our brain and our body accept the use of the CPAP machine, because we have to get used to strapping something on and getting our bodies used to it. And that comes from intervention, that comes from knowledge, that comes from the training all before, not just mailing somebody a machine and saying, here you go, here's how you turn it on, good luck. So.
To get their treatment or get their titration study, there's very little time to talk and educate a patient. I mean, there's so much coming at them. You're putting this on them. You know, they're going to have more things on their hair, whatever. I mean, it's really a lot. And I became so discouraged, I guess it was, back in, you know, a couple decades ago, that we couldn't, as sleep professionals, we couldn't help these people beyond them being right there in the sleep lab. We couldn't give them the education in that time that they deserved. And yet there was no other thing. It's just like he said, you know, they would mail them their CPAP and that was that. Here, put this on. Well, first of all, if you don't educate a patient about the physiology of the upper airway while awake, when it's nice and open, and while asleep, that it's going to close, they're not going to understand this bolus of air coming to the back of their throat. But if you explain that and you try to get them to relax and they accept the pressure in the back of the airway, you're going to have more success. So I tried very hard to at least get that in, you know, before I would put them to bed and lights out. But the time has come for education to be in another setting, not the same night when they're having all this done, but another time. I mean, a time for them to absorb it and digest it. I think that a sleep apnea patient deserves it. This is why they're all, well, there's so many in the closets, because they just can't get used to that. I mean, it's very difficult. But if you relax and you breathe with it and not against it, and if you give that education to the patient, 9 times out of 10, they're sleeping very well with it. And I know from my colleagues in the sleep labs are the best people to bring that education, because they understand the upper airway physiology. They understand and they can teach that. Now, I went around the country. I went to work for a device manufacturer later on in my career. And I was going around the country educating sleep techs on how to educate patients the appropriate way, the way the patient needs to be taught. And it was called adherence and compliance and all this. Well, lo and behold, this turned into something very ugly down the road. Compliance was used to take the machine away if they weren't using it for X amount of hours. Well, they couldn't because they weren't educated. And I think that everybody deserves education to their treatment. That's all I have to say.
Thanks, Teresa. Whoop. You bring up important points, and we're going to dive into those a little more deeply.
Maybe I may or may not be touching on that. I'd like to thank Dr. Shelley. Testing, testing. Okay. I just want to echo something that Dr. Shelley Burson started out with earlier in the morning. She talked about the lack of education on all the different factors, not just the patients. We're here to basically to educate each other, but the education for those of us who didn't even know what sleep apnea is, that education starts in the doctor's office. It continues in the durable medical equipment place and the sleep at the sleep lab. What I think we are all the victims of is siloed medical care. That each of these things are so fragmented and separate that we, the patients, are not at the forefront. If you have a doctor who doesn't know what the equipment is, won't touch it and won't know how to use it, doesn't know how to set it. You have a durable medical equipment company, can only spend 5 minutes with the patient, won't train them, won't teach them, and frankly don't know what they're doing to begin with. And a sleep technician who doesn't have time during his study to be able to deal with, where does the patient survive in this mess? They are all so busy. And then on top of that, the healthcare insurance companies that come in and then cap off what the opportunities were. You could be educated. You know, don't you have, I don't know how everybody's health plan is, but my plan accommodates diabetes training. I don't have it, but they accommodate diabetes training and nutrition training as part of their overall health coverage. Why doesn't that exist in the sleep apnea area? In the sleep area, thank you. In the sleep area. We are, because of the fragmented approach, the patients are losing. So I would suggest to this organization, find a way to break down the silos. And if there's anything we as patients can do to assist, I would highly, ask us. I'm sure we can all write to whoever or whatever.
Joelle, I couldn't say it any better. This almost has to go way back in time. We have to start just with the training of the healthcare field. You got to remember, this is a profession that's very traditional and very rigid and methodical in how they approach the science. And quite honestly, they've been taught that the amount of work you do on as little sleep is a badge of honor. Sleep deprivation is a badge of honor. And changing that mindset is a behavior change. And that's throughout all of society. We're learning in corporate world, the private world, that once people start respecting sleep, let alone their sleep apnea, their quality of life goes up. So the diabetes community, it has taken them 10 years to get diabetes health education reimbursable. We know it. Everybody knows it. This should become a one-year thing. We have a partner here in the room, Alan Boone from the American Academy of Sleep Technologists, and Teresa, who used to be a part of that. These people are going to be out of jobs soon because, quite honestly, the labs or the Medicare and CMS are saying you need to have home sleep studies. We don't need these people. These people are qualified. They're trained. They need to be out in the field, in the primary care, in the family physician, with the pediatricians, helping us learn how to use these machines. To back up for a couple other thoughts I just wanted to scatter in here that I had on my mind. A lot of people have anxiety about wearing the mask and have the claustrophobia. I have to tell you, my biggest anxiety, and Paul mentioned this earlier, was not having power. When that hurricane was coming last summer, I got my family and we got in the car, and fortunately we could afford to do that, and we got up to high ground, not because I was scared of the storm. I'd been through Hurricane Andrew, but I knew the aftermath and the ramifications of a natural disaster. I knew there would be no power back for about a month before where I lived. And I will not go a day. I've not slept a day, a nap, or anything in 10 years without this. Maybe once on an airplane, so tired I've fallen asleep, and I wake myself up. And I can walk up and down aisles on airplanes and diagnose half the airplane. And I'm sure everybody in this room knows what I'm talking about. So with that being said, to come back to your point about the silos, Joelle, yeah, absolutely. If the sleep component is not factored in, whether it's sleep apnea, everyone used to say, well, you think everybody has sleep apnea. And I said, no, that's not the case. I just know that if the sleep component is not factored in, you don't have the whole story. When I talk to some of the top geneticists out of the NIH or all the top leaders in this world, and they start telling me we've developed cardiovascular protocols and interventions and drugs and all sorts of policies based on a person's life, 2/3 of their life. That 2/3 is while they're conscious. They have not factored in those other 8 hours. And that's not having the whole story. That's not good science. So Melissa, you want to say something? My fellow narcolepsy advocate.
So, actually, speaking here as a doctor's daughter, my dad's a general pediatrician. My grandfather was an old school GP, the kind who could deliver your baby, set your bones, and give you the antibiotics. In fact, he remembers before antibiotics. Yeah, he is turning 91 in September. So, but the thing is, when you could do everything from antibiotics to setting somebody's leg to delivering someone's baby, it also meant you had more time in the office and you knew your patient better. Now sleep is a specialty, so it has to get referred. And so for a general practitioner, I was at the sleep meeting this past week, the big National Sleep Foundation, all that, up in Baltimore. Anyway, at some point they were talking, and it turns out that the average amount of education that a medical student gets on sleep is 18 minutes. Wow. That's a medical student. A resident, and by the time they're a resident, they're treating patients. The average amount of time a resident gets on sleep is 3 hours. That's all sleep. That is everything from sleep architecture to this is what healthy sleep looks like in kids, and this is what healthy sleep looks like in adults, to sleep apnea and narcolepsy and comorbidity. 3 hours. And that's while, like I said, while they're treating patients. The other thing is residents are sleep deprived. They've gotten better about it now. You can only work residents in most specialties 80 hours a week only. I always tell the joke, my dad had been awake for 56 hours when I was born, straight, with no sleep, because he pulled a 36-hour call shift as a resident. Don't have kids in residency, if any of you are going to go into that. He had pulled a 36-hour call shift, come home, my mom was in labor, so he wasn't getting any sleep, and then I took a while to arrive. When he was working, it was 120 hours were normal weeks. Okay, if you're sleep deprived, your memory is not good, and also you're probably not remembering that 3 hours you're getting on sleep. So we need to do better as a nation on sleep education. It's a third of our lives. It should probably be at least an eighth of the education.
I think that's a great place to maybe shift gears a little bit. We want to, if it's okay, I want to make sure we get to another topic before the break. And actually, it involves the question you asked earlier about sleep positioning. If we could have the next poll, please. Lots of issues have come up. We're not in a position to change everything from medical education to the way payers deal with things in the fragmented healthcare system. But there are some medications I know that many of you are using, and we've got members of the FDA Center for Drug Evaluation and Research here who are interested in what types of medications you're using in addition to the other things. And we saw in the survey that even though, particularly in the survey population that was reached, that was high, very faithful users of their CPAP, they still had a lot of fatigue and daytime sleepiness. We talked about that in the morning. So the CPAP was helping their sleep, but not necessarily eliminating all of their symptoms. And Dr. Burson mentioned a number of different medications that are used. There are a lot of comorbidities we talked about this morning. So a number of different medications that are sometimes used to treat those coexisting conditions and sometimes used to address the symptoms of sleep apnea itself. There we go. Others? So how many folks are using, it's hard to tell whether this is all in the room or some by the webcast. Dr. Burson also mentioned the real sort of background need to treat allergies and be aware of different allergies. How many people find that allergies are, a big contributor potentially to the problems they experience, just by kind of a show of hands. And a number of different ways to certainly deal with those, including the medications, some of which are up here, things like neti pot and rinses and that kind of thing, environmental influences, and particularly here in DC where we have lots of seasonal allergies, important contributors. Paul mentioned his use of Nuvigil and some of the wakefulness agents. Other people in the survey talked about stimulants and ways to keep themselves awake, up to and including lots of caffeine. For how many people is that an important maybe rescue strategy at different times, or something you do sort of perpetually, just by show of hands? What are the types of, how do you make that benefit risk? Paul addressed this in his comments of knowing if I take it, it might have some effect on my sleep that night. Would anybody be willing to share maybe how they make that calculation, or what benefits they're hoping to get versus what side effects or downsides they're willing to accept in order to get that benefit? So we will.
The benefits of taking a decongestant. So,
any other medications to help you?
yeah, so I have having had this for 25 years, I have a whole routine, and if I can't breathe through my nose, I can't wear my mask, and so I have to go to Plan B, which is either take a decongestant, or if I was smart, I'd be taking a nasal corticosteroid on a regular basis. And then if that doesn't work, then I have to go to Plan C, which is take a more strong nasal decongestant. And then that I know that in 2 days I'll have a problem, because you get the rebound effect. And so, but it's a calculated risk that I have to take. And then if I have a problem that's really complicated, I might have to take my Adderall, where I have to think that day and beyond. And so I have this kind of strategic way of taking all these things so that I can get through my day.
Hey, does that resonate with anybody else? A strategic sort of arsenal of options that you deploy as needed. Paul, I see you shaking.
I just want to add one more medication that's not on your list, and there are nasal antihistamine sprays. Like Astelin, or and there's actually a combo. It's called Dymista, which is it's a nasal steroid plus an antihistamine. So that might be another option. And my pet peeve here is go get your allergies tested, see what you're allergic to, because tried and true is allergy shots. Immunotherapy has been around for a really long time. Get immunized against the things to which you're allergic, and your nasal congestion may improve that way also.
Good. Other comments about medications? All right, now we're going to get to the positional sleeping. Poll number 10 about supportive strategies. These are big things that can contribute positive benefits without maybe that all of us try to do toward being more healthful and living in wellness. And I want to be sure we talk about weight loss. Celeste, you brought this up in your comments, that often weight gain accompanies sleep apnea as kind of a cycle of not being as active or not getting as good a sleep, not feeling as well to be physically active. And then once that happens, it's harder to be physically active because you weigh more and it's just more challenging. And we talked last night when the panel met about some of the expectations around weight loss once you go on to CPAP. And Carl, you mentioned that the research so far yet isn't showing that there's weight loss associated with CPAP, even though sometimes we would expect to see that. Yeah, do you want to mention anything about that?
I think one of the things that I do and that I've used in a lot of my presentations, which I've learned since I've been with the association, is preparing your bedroom for sleep. And there's a lot of ways that people don't realize within your own environment and helping manage your sleep, which is helping manage your sleep apnea. We all have all our gadgets in the bedrooms, and we have the little light on from the cable box and the little light on from the TV for our chargers. And you'd be surprised, sometimes go in your bedrooms, turn off your lights, and see how bright that room is. Your room should be dark. You need to set that. Then it's also part of what we have on our website, the 10 Commandments of Sleep. Use your bedroom for what a bedroom's supposed to be used for. Okay? Don't do other activities in there, and you will be able to manage your sleep a little bit better. You start getting yourself on a routine. You know, you go to bed at 9 o'clock or 10 o'clock or whenever it is, and you sleep till a certain amount of time. And all these little factors really help, and I encourage you, if you've never seen it, it's actually pretty good, look at the 10 Commandments of good sleep. And by doing those, which of course, and a lot of them are on there, the weight loss, the alcohol, that type of thing. But some of the little things that we don't consider, and it's on, is it still on the site, the 10 Commandments of Sleep? It's a great thing to look at.
Carl?
Yeah, I think with the relationship between sleep apnea and weight loss, when people are waking up for 10 or 20 or 30 or 40 or 50 times per hour, some of the research shows, Dr. Eve Van Cotter, who was the keynote speaker at APSS this past week, what she showed was that you can actually bring on diabetes in normal folks by just sleep depriving them. And so you think about the average sleep apnea patient who's having 10 and 20 and 30 arousals. So you'd think if you reversed that, there'd be a natural kind of reset of the metabolism and weight loss. And unfortunately, what we're seeing with CPAP patients is we're not necessarily seeing that the weight naturally comes off. And I think the field was relatively surprised by that. So some of the meta-analyses now show that it doesn't look like with CPAP therapy that not only does weight not come off, but there may be small weight gain associated with CPAP use, which is an unfortunate finding. But I think it also speaks to the fact of how important a focus is on the behavioral recommendations to engage in good health behaviors and diet.
What are some other strategies people are using? See up there, certainly the sleep positioning, as mentioned by the gentleman in the back. Paul?
Low tech, low expense. I tape my mouth shut with a Band-Aid. And the reason a Band-Aid, because it's got the gauze in the middle and my lips are sensitive. The reason for the Band-Aid is because it's got that gauze in the center that goes over the lips, so I won't peel skin off my lips. But I take meds that create dry mouth, and you know, I probably would breathe through my mouth every night, part of the night, if I didn't do this.
Wanted to add another ENT anatomy comment here as well with an anecdotal observation, and that if you have a deviated nasal septum, there is some evidence to suggest that if you sleep with the deviated side down, the obstructed side down, it will allow a larger airway on the good side to be up, and your sleeping should be better. If you do a sleep study in the lab, they should be able to track not only supine on your back, but also right and left. And sometimes they get a little bit lazy and they say supine and non-supine. As an ear, nose, and throat doctor, I want to know right or left. So the cheap, easy test is just plug your nose and see which side is more blocked or not, so that at least if you have to sleep without your machine or anything, at least sleep with the bad side down.
I'm sorry I'm talking so much since this is not my condition, but I did, since the man with the ingenious Band-Aid solution, which I had never even thought of, that is clever, brought up dry mouth. I didn't say anything when you were talking about drugs, but because we do have patients who have both OSA and narcolepsy, and some of the drugs for narcolepsy, particularly Xyrem, is a respiratory depressant. So treating somebody with some of the medications can be tricky with the comorbid conditions, and we need better and more options, particularly in terms of sleep consolidation drugs for narcolepsy that don't also depress respiration for people with sleep apnea. And I know that Xyrem has been used in some sleep apnea patients, and so I'm sure doctors can talk to that. But that's a need, and we need pediatric stuff that is designated for pediatric patients. We need stuff for excessive daytime sleepiness that's designated for pediatric patients, and the thing the FDA can do is incentivize it so that we are getting drug companies to, nobody wants to do tests on kids. You have to incentivize it. And the FDA can work with policymakers to encourage drug companies to do that testing. I've been on off-label drugs for years for excessive daytime sleepiness. A lot of our patients that have both are on it, and we need better ways to deal with that with pediatrics, and that's something the FDA can do.
Thanks for that. Yeah. Adam, did you want to comment to that? We haven't talked much about the kids and the treatment aspect.
Which you know is dear to my heart.
I do.
So there's one thing that I beg of the entire healthcare community, and it's really pandemic at this point, but before any child's written a script for Adderall or Ritalin for any sort of ADHD diagnosis, if they're not having a sleep workup, that doctor is not practicing at the top of his license. So, you know, that it's not the child's fault that they're bouncing off the walls. It's not the child's fault that they're bedwetting. That's the body's way of saving them and waking them up at night. And we have to start teaching the mommies and the grandmas and the women who are in their third trimester of pregnancies about what to expect when you're expecting, because there's a lot of stuff that we know about sleep that's not in those books that the laymen's are reading. That's more of a public health sort of comment, but it comes back to every pediatrician scares every mother and every father about sudden infant death syndrome, and we're not saying that all sudden infant death syndrome is pediatric sleep apnea, but a good percentage of it is, and really the only difference is that a 1-year-old baby can roll over and catch its breath. And we all take down our red flags, you know, after one when that baby can roll over, but that's really when our guard's got to go back up. It's just, you know, I caught my child sleeping in child's pose. She was naturally already protecting herself. She had her butt up in the air, letting her tongue fall forward, and she was forcing air into her diaphragm. And once we teach mommies to look for that and that a child's wedged up against the bed, these are called telltale red flags for a sleep disorder breathing issue. And that's just got to become part of Maine society. It's got to become part of the FDA. It's got to become part of everything. The healthcare, learning healthcare systems, our school systems, you name it. So with that being said, that's about all I got.
All right. Well, that's a great place for a break. We're scheduled to take, let's take a 15-minute break, and I do invite everybody to come back and join us at 2:45. We're going to dig into some of the challenges that have already come up, but to put a little more focus on those. Then we'll hear from Katie O'Callahan from the FDA Center for Devices and Radiologic Health, and then Adam and Carl will wrap us up. So take a bit of a break. We've got some refreshment outside, and then join us back in 15. Thanks. Good afternoon. We're here for the last session of the Awake Sleep Apnea Meeting. And in this session, we want to focus on some of the barriers, both to diagnosis and to treatment, and sometimes they're intertwined. I was just having a conversation about the sleep testing, which is used both to diagnose and then also as a gateway to different therapeutic options that you may have. So let's start with a poll while folks filter back into the room and people come back and join us online. Eric, if we could have poll number 11. And this one asks about what challenges, top one or two, that you encounter in sticking with your treatment plan. And that could be any of the things we've talked about and other strategies that you might deploy, like Will mentioned, having a sort of menu of options and you pick what you need for certain circumstances. You can do one or two, I think, is the way it's programmed. Top one or two. And I'm going to share some of what we heard from the survey as well. All right, so no surprise, the problems with the equipment itself, comfort, fit, convenience, settings, instruction, rating high on this list and also with our survey population, and right about the same, well, keeps changing. In the survey, it was 50% said uncomfortable and 46% inconvenient. So those are maybe a little higher than what we're seeing here. And I imagine that for most people, they're thinking CPAP or oral appliance with these. Doesn't necessarily restrict it to that specifically. We've heard already today a lot of the challenges with using the machine, keeping update as far as newer models and the access issues that you may encounter. I don't know if everybody has kept their full collection, like Joelle told us she had, of 24 different masks. Anybody top that number over time? And we've heard today about the lack of information or appropriate education, counseling, training, access to knowledgeable folks. For how many people is that in itself been problematic? Just not having the right level of instruction, ongoing support that you need. Certainly something that ASAA and our partners here in the room can think about. How do we fill that gap? That seems like kind of a low-hanging fruit. We talked a little bit about the sort of physical challenges of being, feeling like an octopus is on your face, like getting wrapped up in the hose. Just had a conversation with somebody about at the break of different issues that you experience because of the treatment, maybe with more frequent urination at night, some of the issues that kind of go hand in hand with the condition itself. What is a night of sleep like with a CPAP machine or an oral appliance? Tell those of us who haven't experienced that what that feels like. Some of the physical things, in addition to getting the good, positive benefits. What are the downsides?
The downsides are, for most people, I'm sure every one of us has a glass of water beside our bed, because we all have dry mouth, whether we're using full face mask or nasal. When, depending upon what you eat, a lot of us are dealing with some sort of reflux or silent reflux issue. And I'm sure the connection hasn't ever been made, and probably in this room, that when you're not breathing, you're having an obstruction, It's the brain's way of sending a signal to the stomach to shoot up some acid that comes up your airway. And that's actually protecting you. Just like the bedwetting with children and just like getting up to go to the bathroom at night. You're having a biological reaction that's arousing you, telling you to go to the bathroom. Some of the negatives of CPAP, it's hard for me to bash it because without this machine, I'm a dead man. Quite literally. Without electricity, I'm a dead man. I don't know if it's because of evolution, but seeing my daughter, and just to go back a little bit in time, she will bite into an apple and has twice as wide a bite as me at 10 years old than I do at 40 something. And the reason for that is since we caught her early with the early recognition and her bones are still malleable, we could expand the airway. We could eliminate the deviated septum because that top palate's getting flattened out and it's not pushing all the way up. When I first was diagnosed, went and said, okay, I have a deviated septum. Let's go get it fixed. Those 2 weeks of post-surgery and having my surgery were the worst 2 weeks of my life. Anybody with any sort of sleep disorder breathing needs to make surgery, in my opinion, a last resort option. You are playing with already a narrow airway, and to go under sedation, you're really playing with fire no matter who you are. It doesn't discriminate. My doctors, everyone, they thought I was manic after it. I was so inflamed, and I was still using my CPAP. They didn't pack my nose. But I knew that I had to wear that CPAP no matter what. And to this day, that I made it through that. You do what you got to do to make this thing work, whether it's elevating your bed, whether it's putting a fleece over your tube, putting liners. One of our partners is Remzies, who've been great. We send out samples with our CPAP assistance program. There are tricks to the trade. We live with this chronic disease. I wanted to say something earlier. This is the only disease, unlike hypertension and unlike diabetes, that if you're not using your machine for a certain minimum amount of hours, which are arbitrary in itself, and for a certain amount of time, they will literally come back to your house and take that machine out of your house. If you're not using your diabetes medicine, what do you think the reaction is? They don't come and take the diabetes medicine out of your medicine cabinet. They bring you more medicine. They want to make sure you're going to get the treatment. So it's the total reverse antithesis. So this one arbitrary hour of this rule about having to use a machine for 4 hours, so people are wearing it or having other people wear it for them just so they can make sure that someone doesn't take it away from them until they get adjusted to it, is truly insanity. The definition of insanity is doing the same thing over, expecting a different result. So, Michelle, you want to say something? Yeah. I've already lost my, now you can see one of my side effects is ADD.
Sure, just to highlight one good thing. I used to have a respiratory therapist who worked with me, and as soon as I would diagnose somebody with sleep apnea, and we would check the insurance, and he would be in the next room and get them a machine right away. It was a really nice way to practice. It fell apart kind of financially, but it was really nice. And the one thing that I remember Dan telling me was why he loved his job was because the next day after he hooked somebody up with a machine, he would go to their house to see how their night went. And he said time and time again he heard, "You just gave me my dreams back. I have not had a dream for years." And that was why he stayed in the profession. So I thought that was really cool to be able to tell patients that, you know what, you might get some dreams back. Now a caveat. People still do get up to go to sleep, to go to the bathroom in the middle of the night, and sometimes that'll happen 3 or 4 hours into having used their PAP therapy. And they may go to the bathroom and say, "I feel really good. Boy, that was awesome. I'm done." And they'll go back to sleep and not put the machine back on. And the problem is that REM blocks happen every 90 minutes, and they get longer and longer as the night goes on. The longest being probably at 5 o'clock in the morning. So that is when people have heart attacks and strokes. So don't be seduced by feeling good because you feel better than you used to. You got to use your therapy, and the most important time to use it is early morning.
Joelle, you were going to...
Wow. Thanks, Dr. Shelley. I haven't dreamed in 30 years. Even with a CPAP machine, I'd love to get my dreams back. Can I have that guy come to my house and do whatever he does? Does it work? Will he fly to Los Angeles? Yeah, he's cute. Oh, that's good. Both Dr. Shelley and Adam brought up something that I want to discuss that's embarrassing but needs to be said, which is let's talk about bladder control and the CPAP machine, because it's been a real issue in my life, because I can't get a good night's sleep if I have to keep disconnecting myself from the machine to go to the bathroom. When I come back and I remember and I'm still functional, I can hook myself all back up with the mask on, maybe lucky fall enough back to sleep. That's not always the case. Sometimes I reconnect and I'm lying there and I don't fall back. I don't get that REM. I don't get past light sleep into that miracle Peter Pan stuff. And I really want it. I really miss it. I'd like it to come back. Now, it's nice to hear it's saving my life, but I'd rather be asleep, you know. And I just would like to know if there's any more, has there been a correlation? Has there been any study to help relieve me? And I don't want to take medication for it if it's trying to keep me alive, you know. So I'd like to know, anybody else have, comments?
Just quickly, someone just mentioned about having a dry mouth. There's a over-the-counter product available in any drugstore called Biotene. It's next to the mouthwashes, and if you rinse your mouth out with it before you go to sleep, it'll keep your whole mouth moisturized for hours.
To the back.
Actually wanted to address the nocturnal, well, it's what we call nocturia, having to go to the restroom all the time. Oftentimes that's a side effect of the apnea itself. When somebody goes through a severe enough desaturation, the heart releases basically it's a hormone, and it is a urinary promoter, diuretic peptide. Okay, so as you're going through your desaturations through the night, more of the ANP is being released. Oftentimes it'll lead to the point where suddenly I have to go to the bathroom 3 hours later. I get up, I go to the restroom, I also blow off all the residual CO2 that my body's accumulated at the same time. I go back to sleep, I start the cycle over again. Urinary frequency during the nighttime is typically an indicator, while on CPAP, that you're not at the right pressure. More often than not, you're not at the right pressure. You may need to be reevaluated. Now, does that necessarily mean that you have to go into the lab? No, not at all. They can oftentimes do this on a rental piece of equipment and get a download. And they can look at that download, they can see where you've stabilized at on an AutoPAP, and then make the readjustment and help correct that piece. Now, something else about dream content. Typically, the most vivid dreamers are the ones whose REM period is the most highly fractured or interrupted. More often than not, you will remember your dream content as you awaken out of REM. So going on CPAP and being well treated on that oftentimes means you're not going to dream. There too is another indicator of proper pressure. So you may want to check with your physician on that, or your sleep medicine specialist. Just kind of take a look and see if there's a way to, if you can get a loaner device that can track your time, or that can track your pressures. And they're very sophisticated pieces of equipment now, and they can do this. But if you reduce the amount of apnea, the amount of respiratory disturbances during the night, atrial natriuretic peptide release will decrease. And barring any other pathology, your trips to the bathroom should decrease as well. There's a big study in Birmingham, Alabama about that, probably about 20 years ago. And it was actually initiated by a nurse practitioner who was looking at urinary incontinence frequencies inside of nursing homes. She got into the place only to find out they were all apneic. Turned around, got them treated. What do you know? Didn't have the nighttime bedwetting. I hope that helps you.
I want to pull on something you've just talked about, as well as comments that Erin made during her panel conversation about the benefits of having kind of an immediate feedback loop. You've just described a fairly complicated procedure of knowing whether the pressure's right, and the kind of ongoing testing that some people have to go through in order to keep their machine or get a new machine. Erin, you spoke to the benefit of having an app that you could look at every morning and see how well you were benefiting from your CPAP therapy. How many others are also getting sort of that immediate feedback and access to data that helps them make adjustments? Adam, Will, I
can tell you, as having worked previously for one of the manufacturers, in my role, I'm an old sleep tech. I've been doing this more years than I care to remember. But I started a career transition into clinical research probably about 25 years ago. And when we would do the testing of the new CPAP systems, and that didn't matter if it was a tubing, if it was a mask, or if it was the actual device itself, we went through extensive clinical research trials. We would take those units home, oftentimes ourselves, and wear them just to see what that experience was going to be for that patient. I'll use the term loosely, subject, simply so that we knew how to guide them better, so that they were, if they ran into a situation, we could better explain it. But the funny part about it was, I had both sides of that equation on that app. There's an app out there that's for the physician side and one that's for the patient side. And I had access into both of those. It's robust, and it was great information. And if you've got an engaged patient that's willing to use that, your treatment will get better. Now, in her case, with the nighttime situation there, you could take a look at that app and see, do you have a good seal? Are you having any events during the night? What is your mask? Is your pressure fluctuating? That's immediate information right there for you.
Will, can we get a mic over to Will, please?
Yeah, this brings up the subject of data. So I think we're seeing the rise of the patient, or the rise of the participant, if you want to call it that. We don't ever say subject anymore. And I think, when you have a chronic condition like this for 15, 20 years, you deserve to be able to see the data, not just the summary data. You deserve to see all the data, because it might be that you might be a scientist and you put it through your little Vegematic and come up with some conclusions about things. There's summary data on machines and that kind of thing, and that's not too bad, but it's insufficient. I think now, given that the level of sophistication and the level of computer access and that kind of thing are increased so much. A word of caution on data? Yep.
Your chart doesn't belong to you. So if that's something you're interested in, get a hard copy or get a copy in a format that's readable across universal platform, not just by a certain EMR, because your chart data doesn't actually belong to you. It belongs to the doctor or the clinic. And so if you're like me and you get hit in the area where there's the division between the electronic medical records and the paper medical records, and they choose not to scan some of that over, my MLST that I needed to be diagnosed with narcolepsy no longer exists, and I have no recourse, and they didn't inform me about it. I found out about it by accident. So if you do like having all the data, get a hard copy or get it in a universal format, and that's great, and it's awesome that that data is now available.
I'd add a couple of caveats on top of that. It's not only do are you entitled to your data? It is your data. It is our data, whether it's sleep apnea patients, cardiac patients with pacemakers. You're now seeing a big movement, and the FDA is very well at this with the type 1 diabetes with the hashtag We Are Not Waiting. We don't have 90 days to wait to get to see a clinician to figure out what's going on. This data, this technology, we have to start making work for us. We need to start working with our doctors in a shared decision making. This data that we're looking at is different for each manufacturer. So when we look at it and we're comparing apples to oranges to pears, we're not comparing apples to apples to apples. So the field of sleep medicine has been, I dare say, negligent in that they haven't demanded that these algorithms be publicized and shown to see really what's going on. I know that's not news to everyone in this room necessarily wants to hear, but we want our data, and right now the DMEs are the stewards of it. And those, we don't know if these DMEs are going to be around for the long term. The spreads are getting smaller, and the business is squinching up. The manufacturers are obviously getting ready to go direct to consumer eventually down the road. And the truth be, with this type of therapy, it is more dangerous to take a pill or drink a glass of wine before you go to sleep than it is to use positive airway pressure. And right now, we are forced, because of the prescription model, that if someone witnesses you having an event, an observed witnessed event, elbows you, you should be able to walk into your drugstore, rent or buy a machine, and try it. If it works for you, great. If it doesn't, try something else. That's it.
I don't want to get too deep into the policy issues of OTC medical devices and
And I'll bring it back down to the clinical issue, because I thought that was a really interesting exchange. Both Alan and Shelley, I think, were right. Sorry, I'm a soft talker. Closer. Both Shelley and Alan, I think, were right. One of the key things is, what's the patient hearing? On the one side, if I have dreams, CPAP is working. If I don't have dreams, CPAP is working. So which one is right? They both are, in a sense, right? Because there's good arguments for both. It just depends on how REM is being had that night, and when someone wakes up, and what the reason is for waking up. And the reason why I wanted to bring that up is because the one big thing we're missing here, and this is to get away from the challenges with the therapeutic devices, is what if we had a way to measure it so we didn't have to take a guess instead of a subjective guess as to what was happening? Wouldn't it be great if we could measure sleep on a regular basis, or even on an intermittent basis, so we didn't have to guess? We could actually take a look and see what the therapy's doing, how someone's breathing, and how someone's sleeping. So in some of my research projects, what we did, we had the opportunity to do what we called CPAP efficacy studies. So we had this big CPAP adherence intervention program, and we had these medical grade type 3 devices. So we'd send someone home after a month or 2 or 3 with the type 3 device, and they could wear that for 1 or 2 nights. And we could combine the data from the type 3 device on top of the CPAP data and look at it together. So we could see, were there a number of apneas or hypopneas happening that would then result in pressure changes, or we could see whatever we wanted to see. What was missing from that, though, was a measure of sleep. So we didn't have the EEG. Wouldn't it be great if we could do that? So I have a whole lot. I could talk for 30 minutes on consumer technologies, medical grade technologies, and how we should measure sleep in the home environment. But one thing I'll say was, instead of moving away from adding sleep, it was really interesting when someone naturally took PAP off in the middle of the night. We had a night with on PAP and then off of PAP, and we would bring the participant in, take a look and say, this is your brain, this is your sleep on PAP, this is it off of PAP. And talk about motivating, because what you were talking about is you miss those REM episodes late in the morning. And if a lot of people are using CPAP 3 to 4 hours, they might be missing those really important REM episodes. So I'll stop there. So if we could approve some kind of device that could measure sleep and breathing in the home on a regular basis, it would be phenomenal, and I think go a long way.
Well, and it also speaks to sort of the need for outcome measures that measure what is a good night of sleep to the patient. And is it having dreams again? Is it feeling rested in the morning. We've heard a lot of different versions of what those important outcomes are, right? Being able to function during the day, not falling asleep at work, not falling asleep at a traffic light or going 60 miles an hour, flying a Navy plane. Oh my God. All important measures, but no uniform way to assess that.
More dangerous and scary right now, Kim, is that we have so many people walking around with these consumer wearables that we all have on our watches or on our wrist, and we think we know as laymen's, because we're a little bit uneducated about what kind of sleep we're getting, literally what stage. And let's be clear, these watches that are measuring actigraphy, they're having a hard time just getting the step count right. So to think that they're taking the next step in measuring stages of sleep, let's be realistic about this. It's not real.
Yeah. One more comment, and then I'm going to move on to the financial issues. Yeah.
Carl, don't mean to steal your thunder here on the wearables, but the thing about wearables, you got to be very, very careful. So few of them have actually gone through FDA level scrutiny clinical trials. They've not gone through true, proper validation and verification through V&V. And it is consumer beware. And you cannot get hooked on looking at these things unless they've actually been through an FDA level trial and think it's going to be correct. Because if you take that into a physician, they're going to consider that as nothing short of going to Dr. Google. Really. Because we really don't have the means to validate something like that in the office. And your comment to that, consumer grade versus medical grade, there is a very substantial difference in there. And those medical grades will have been validated through that process. So just as a precaution, and as having seen it personally myself in my own sleep, and again, knowing what I know about sleep architecture and such, looking at the output on these things and then kind of looking at it from having my own sleep studies done over the years, didn't match a bit. And I mean, it was significantly off. So just grain of salt with any of the units that you use.
And it's not limited to just sleep studies. John Wilbanks, the citizen scientist, data guru who was here with us this morning, did a study, looked at all of the proliferation of apps that you could take a picture of a mole and some kind of algorithm would tell you whether it was cancerous or likely to be cancerous, and it was all over the map. So it's
manufacturers in the medical area are putting out these devices themselves, and they are following with this level of scrutiny.
Yeah.
Those I would have no problem with, but it's, the ones that you can pick up cheap, eBay, no.
Yeah.
No.
Okay. The number 2 challenge was related to financial barriers and a whole wide range of things, and we kind of split that out, anticipating this would be an issue. So, Eric, if we could see the next and final polling question, we'll dig into this a little bit more deeply, and then talk about some of the things that fall into that bucket of challenges. Can everybody see that? And you get another top 1 to 2 choices on these challenges. We've heard throughout the day how the sleep test, either a home sleep study or an overnight study, can be a gateway point to either getting the diagnosis, getting the right access to an appropriate therapy, to calibrating the therapy, to getting a different model. For how many of you, let's see, where is it? We didn't ask that specifically. Is getting to a sleep study a challenge? Just by a show of hands. Getting in to see somebody. and I would imagine it depends on coverage and policy as to how often that needs to happen, how frequently you have to do that if you're staying on the same therapy or trying to access something new. Coverage for medications, the high out-of-pocket. ASAA tries to tackle this at least on the front end with helping people get access to equipment and renewable supplies. There's information about their CPAP assistance program in your in the booklets that are out on the table, and urge you, if that's an issue you've encountered, to look into that program. And we already had somebody here who had extra machines at home who's going to make those available to the association. What are some of the other issues, Adam?
Some of the other issues, even if you have full insurance, if you have a high deductible or a high premium, it's not even worth going to your insurance company and having them get your resupplies. You know, my insurance will bill us for $40 for a little cotton filter. I can go buy that online for $5, $10. So it's not most of all my resupplies, I'm out of pocket, even though I have the insurance. So even the insurance standards are just they're skewed. They're way off.
If you are on Medicaid and Medicare, very often you don't get resupplies. I get mine when I do from my physician at the sleep center. I call, they don't respond. The company that brought the machine, they don't respond. The doctor calls, they don't respond. Well, they tell the doctor, oh yeah, they get the prescription. Yeah, we'll take care of it. You know, you better believe I'm totally convinced that they have charged my Medicaid, Medicare account for those supplies, but those supplies never find their way to my house. Right. They never find their way to my house. And so when I go in for my appointments, you know, I have to tell the doctor, I need a mask, I need a hose, okay? And she digs around in the office for supplies that, you know, Big Pharma brings in, okay? Says, hey, this is the new thing on the market, la, 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 okay? And sends me home with that so that I have something. And then, of course, she sends the customary prescription out, and nothing ever comes to my house. So that's definitely an issue, okay? That's very real in people's lives, okay? And like I said, I'm convinced every single time she requests, my account is getting charged. I don't see anything. I have no way of proving that either.
Supply
It's
chain
my word
issues.
against the professional company. And you better know they're not believing me. That's just the way it is. So if you're on, you know, limited income, you're just not going to have it if your doctor doesn't happen to have it sitting on the shelf in the office. You're on your own.
As I mentioned in my presentation, I had some trouble after the fact getting my insurance company to pay for the sleep study. And the reason for this, I learned, is that they thought I should have done a home sleep study first instead of being sent into a center first. And I'm not sure where exactly the confusion arose there, if that's something, the way my doctor should have prescribed it. But I think it's kind of terrible. The patient gets stuck in the middle of that argument between, you know, the doctor and the people who provide the sleep study and the insurance company. You know, when you have sleep apnea, you have so many other things going on of, you know, the fatigue and the depression and the tiredness. You're not in a good position mentally to be a strong advocate for yourself and to go out and do a lot of research and learn, oh, I should be doing a home sleep study, or I should be doing this, or I should call the sleep center and follow up and make sure that they cleared this with my insurance before I went there. So, I mean, the very symptoms of this condition make it hard to be a informed consumer ahead of time. And the other thing is that I think it's very ironic that the insurance companies would be resistant to paying for a study when, you know, living with untreated sleep apnea causes so many very serious health conditions that are far more expensive than a sleep study. I mean, if someone goes into the hospital for a stroke or a heart attack or develops type 2 diabetes, it's extremely expensive to treat those things long term. And so I just find it terribly ironic that an insurance company would fight paying for a sleep study when it could save them literally tens or hundreds of thousands of dollars in treatment costs down the line. So I wish there was something that could be done about that.
I think one of the consistent things we've heard, and Megan will back this up, I think, across a lot of these patient-focused drug development meetings, is the focus of our healthcare system on an acute care model is really not serving well the more chronic conditions and the things we could do in terms of preventing those more catastrophic long-term consequences of things if they were better addressed on the front end. And
it's like they're operating on the penny wise and pound foolish model. You know, they want you to have the cheaper home version rather than pay for the more expensive one, because they're not thinking about the fact that, you know, if we keep going on the low end going in, it's going to cost us more in the long run. They don't get it. They're so focused on, I want to save a dime right now. Okay? Never mind the thousands later on that dime is going to cost me. So, I mean, I wonder, are these people educated in these companies?
Annual shareholder report, right?
If I could touch on the HSTs for just a quick moment. You know, the industry did bring those to bear to help with costs, because we are in you know, let's face it, medical costs continue to go up and up and up. Now, HST was brought about for somebody that, you know, if they just had a simple apnea, no other issues, that's who that's really designed for, is for somebody who has straight up sleep apnea. But if they have comorbidities such as diabetes, hypertension, other maladies, any of the, you know, COPD, congestive heart failure, those folks are to be excluded from HSTs. They're actually to go straight to the sleep laboratory. So if there are compounding issues within that patient's health care, they really need to go to the sleep lab. HST is an inappropriate fit because it's just not going to be able to record what's necessary.
Yeah, I think that's a very true statement.
Right. Right. That's right. Over the years, there have been other maladies that have been found during the night, you know, that have further compounded overlap syndromes and such.
Yeah.
So, again, we need to help be able to rein in some costs on these things, but in a responsible way. And that scripting for that HST is only designed to go for somebody who just simply has the given appearance of having OSA. It's not for the narcolepsies. It's not for the periodic limb movements and different things.
Yeah. Well, I think a lot of the issues that have been raised, particularly in this afternoon session, have demonstrated the importance of forums like this to surface a lot of the day-to-day practical issues and barriers that all of you face in both the process of getting good care and getting good benefit from the treatment options that are available, as well as the need for an expanded array of options that can be deployed strategically to better meet all of the needs that you have. This is a first meeting of its kind for the American Sleep Apnea Association. It surfaced, I think, a lot of opportunities for the association to come in and start to address those gaps, to bring other agencies and policymakers to the table to try to address the myriad needs that are out there that are unmet in the community. And I know it's been a rich and informative discussion for certainly the members of the board that are here today. I'm going to invite Katie O'Callahan to come up and summarize what she, as a member of the FDA staff and somebody who's focused the past several years on bringing more patient-centered thinking to the agency's work, summarize for us today and also share with us how FDA uses the kind of information that all of you have been so courageous and generous in sharing. So, Katie, welcome.
Thank you to Kim and to Adam and to the Sleep Association and everyone who was involved in putting this day together. It's certainly been a learning experience for me, as I'm sure it has been for all of you. I've been asked to provide a summary of some of what at least I learned and heard today, as well as Kim has asked me to speak about what does FDA do with the information that we learn in patient-focused medical product meetings and other interactions of this kind. So, but before I get started, and I apologize, I missed the morning, so if this has already been done, please bear with me. I always think it's helpful to get an idea of who's in the room in terms of what perspective we represent. So if you are a patient, family member, caregiver, or patient advocate, could you please raise your hand? Wonderful. And I'm not the only FDA person. Who else here is from FDA? Okay. And I know we had a few more in the morning session who had to leave. What about industry consultant, past or present? Okay. Healthcare professionals? And let's see, scientific, academic, clinical, academic community. Okay, and anyone who I didn't include. Citizen scientists, wonderful. Okay, so part of why I do that is I think it's helpful to see that we really do have a mixture of perspectives here. People see things from different views, and we all, I think, at the FDA have been humbled over this many-year journey that Kim outlined to really recognize that patients and their families really are experts in the disease and the condition, and we're all really learning a lot from this community. So thank you for this meeting, which is a continuation in the journey for all of us. I think, the other reason I do that is to highlight that regardless of which stakeholder group you come from or represent, we do have a shared goal, which is to improve the health and quality of life for patients. And so that's what we have in common. That's why we're really all here today. And that journey begins with listening and learning from the learned wisdom that patients and families have accrued over the period of time that they have been living with this condition. What is FDA doing with this? Well, for those of you who know FDA exists but may feel there's a bit of a black box in terms of how we operate, I like to simplify it and say that essentially we are looking at whether or not the benefits outweigh the risks. And we do that in consideration of the impacts of the untreated or undertreated condition on the patients, with a consideration of what the evolution of the state of the science and the state of technology is. And really, I think we're increasingly starting to be able to incorporate the patient perspective more substantially in that weighing of the benefits and the risks. And so there are three particular areas I want to highlight in terms of, concretely how are we using this in our work at FDA. The first is in the understanding. So in weighing the benefits and the risks, it's not in a vacuum. It's really in an understanding of the impact on patients. And so clearly, meetings like this deepen our understanding of that part of the picture, which is really critical. The second is the science of patient input. So more and more we're seeing an evolution and a maturation of the methods and the tools and our ability to do scientific studies. And the reason this is important for FDA and the scientific and clinical community is that as we do that, we're able to begin to elevate what we're hearing from the voices of patients in meetings like this to evidence that can stand alongside with the clinical studies and the other technical information that we look at when we consider these benefits and the risks. And that's really important in our evolution on this journey to be able to continue to do that. And the third is the recognition that patients and patient organizations, while they have always been involved in patient support and raising awareness in the population and raising funding for research, are really increasingly starting to actually get in the game of medical product innovation, which is critical because medical product innovation is a team sport. And in the early days, it was a team sport where we were all working together on behalf of patients, but now increasingly we're working with patients as partners in trying to improve this state of affairs for everyone involved. And so when I summarize what I heard today, I will try to draw parallels to those three areas because I think that might help us to, from our own perspective, from our own stakeholder view, think about what we can go back and be actionable upon. So I certainly have a much richer understanding of the impact of this condition on the daily lives of patients, of their families, of everyone in the household. And I don't have this condition, but as a mother of an 11-month-old, I can at least identify a little bit with the impact of long-term sleep deprivation. But I think we also learned a lot about the diagnostic odyssey, as I've heard it termed by some patients and patient advocates, where in some cases over 6 years, probably longer in some of the anecdotes that I heard today, before we really arrived at a proper diagnosis. Lots of delays, misdiagnosis, and other challenges with the actual process of the diagnostic process. The management, once we get to treatment, I did hear that quite a few patients eventually got to a point where treatment was working, but that, even having gone through the diagnostic odyssey, then there's learning how to use it properly, finding the right fit, all of that, the challenges that go along with that. And then barriers to sticking with the therapy, and also barriers in other arenas like financial barriers and access to treatment. So that's understanding. From the standpoint of the science of patient input, the opportunity for apps, given all the caveats that were mentioned, which are real, apps and other tools, they're evolving. They are getting better. And one of the most promising opportunities from the FDA's perspective, and with patient group involvement, I think we'll be able to accelerate that in ways that are useful. The promise of this is that we'll move from this peephole view that we get from a clinical visit to a much bigger picture view of the impact of the condition on the full scale of the patient's quality of life. And that will help us overcome some of these other barriers. There are also opportunities in some of the other areas of science of patient input that FDA is involved with, patient-reported outcomes, patient preference studies that may or may not be the right fit for this community, but we're certainly seeing increasing uptake across various patient communities in those scientific areas. But really the point I wanted to emphasize the most was the team sport. So I think there are a lot of potential opportunities to bring patient citizen scientists, patient innovators, patient people who have experience with the business aspects of healthcare and all of the other parts of the ecosystem that are involved to really get into the game and come together as a team to try to start to tackle some of these barriers collectively as a group. So those are my thoughts that I want to leave you with, and thank you again for allowing myself and the other FDA folks to be a part of the listening and learning for today.
Thank you so much, Katie. It's always, it's been a real honor and privilege to work alongside you and members of the CDRH team and the CEDAR team to see how far we've really come in respecting the roles and the opportunities that exist for people like this who have that lived wisdom, I love that phrase, to really, for you to benefit from them, for the life sciences innovators to benefit from this really rich experience. So thank you for pushing this forward at the regulatory end of things, and we'll all work harder to bring it to you on a nice silver platter. You'll even take a paper plate, I know you. Before I turn this over to Adam and Carl to make some closing remarks, I did want to point out these beautiful portraits along the sides of the room are provided to us by Gilles Friedman, who is a notable patient advocate and disruptor himself. He started a company called Smart Patients that some of you may know, along with Ronnie Zeiger. He's also a very renowned photographer and artist. He's taking portraits down in the lower level of the hotel. If anybody, and we'll open that up to anybody, would like to have one of Gilles Friedman's originals, you're welcome to just take the staircase downstairs and we'll get you to the right place. He's got a little photo studio set up down there. And ASAA will be using these to just help paint the face of OSA more broadly. And with that, I will turn it over to Adam and Carl to wrap us up and make some closing remarks.
Sure. Age before me.
And Carl, I'm asked to have you put the microphone right here for the no.
Thank you. My name's Carl Stepnowski, and I've been going to Awake group since 1996. That was my very first Awake group that I attended as a graduate student. The reason why I bring it up is because I learned more in that hour or hour and a half session with sleep apnea patients than I did being in a lab for the year before. And what I saw was a resilience. I saw innovation. I saw people who were taking care of themselves. And I learned a lot. And I learned so much in that time that it's amazing to think 22 years later, here we are having what we're calling the biggest Awake group we've ever had. Historically, the Awake group's been focused on sleep apnea. How long ago was it? 6 months, 9 months ago, Adam and I took a close look at it, and we said awake, alert, and keeping energetic. It's not just sleep apnea. And so Adam's been a huge driver of the ASA over the last 5 years and has really helped convince me to say it's just not sleep apnea. It's taking sleep apnea. It's about good sleep, and it's about good sleep health. And it's been an amazing journey over the last 5 years. So I just wanted to preface that preface my remarks with that. I also kind of wanted to more address some of the research that's been going on. I think I've always seen the power of the patients from that very first Awake group, and I've always been drawn to doing more applied kinds of research. But what I realized was, even though I was doing it side by side with Adam and Will and other patients, really has changed what I've done. And I think if we can continue and start to have the world's biggest sleep registry and all of our grand plans, it's going to be really something. So in terms of observations from today, want to do it under the framework of the sleep journey. And that's a phrase we use a lot because it truly is a journey that folks go through with sleep apnea. If we think about the journey from when the symptoms first started to diagnosis, that's a journey in and of itself, and we've heard a lot of those stories today. If we think about the journey from diagnosis to treatment, should be simple. It's clearly not. That's a journey in and of itself as well. And then even once on therapy, even once some folks are well established, it can continue to be a journey for a variety of reasons. health changes, decisions to make treatment changes, et cetera. So when we put it all together, it's just a tremendous journey that all sleep apnea patients are on. I'm going to kind of cover some observations for each one of those three phases. It's simply taking too long for our healthcare industry to identify when someone should get that sleep study. What should potentially be days or weeks or maybe months, instead, folks, it's taking years, and we hear from the stories from this meeting, decades, and that's clearly too long. There's a lot of reasons for that, and we hope to be a driver to help shorten that time frame. The second aspect is the appreciation of daytime symptoms. I think one of the things we're hearing is that I've had daytime sleepiness and the effects of chronic sleep deprivation for years and decades. And when you have the chronic sleep deprivation for that long, just like Shelley said, it starts to break the body down. And we have to do a better job of appreciating that. We clearly heard that there's societal factors. There's lots of other reasons why we minimize the importance of sleepiness. It's macho to not do it. We heard that last night during our patient roundtable. But what I'll say for sleep apnea specifically is sleep apnea was recognized as a real disease when it was associated with mortality, when sleep apnea was associated with cardiovascular disease, when sleep apnea was associated with hypertension, and when sleep apnea was associated with diabetes. People think that those are hard outcomes, and so that means sleep apnea must be real. When we think about it, think about the stories we heard today for the effects of chronic sleep deprivation. We heard about career problems. We heard about performance problems. We heard about real car accidents. It doesn't get more real. The effects of sleepiness don't get more real than some of the stories we heard. And I don't know what it's going to take to elevate it so that it gets identified and recognized and dealt with earlier, but that's one of the things we'd like to do. And I think by telling it through the power of patient stories and the power of getting those stories out, just like we're doing here between portraits, interviews downstairs, writing the report from this, writing the report up from the survey, we need to get the word out about the real effects of sleepiness. It's going to be an uphill road. I remember Bill Dement walking onto Congress back at a sleep meeting about 18 or 20 years ago. I mean, this is something that's been tried. Don't know how to do it, but we're going to give it a try. And then the last observation are treatment options. Clearly, for folks who have fairly severe sleep apnea, when CPAP is at the right pressure, worn for the right amount of time, and the right mask fit is there, it's a phenomenal therapy. What we need, though, we have a lot of more folks who are being diagnosed with mild sleep apnea, moderate sleep apnea. The field, if anyone was at the sleep meeting this last time, there's a lot more research, not just on looking at mild, moderate, and severe, but looking at symptom clusters. So sleep apnea with insomnia, sleep apnea with no symptoms, sleep apnea with chronic daytime sleepiness. Better understanding of the symptom clusters and what therapies or combinations of therapies are best. So we really need the research, clinical community, patients, co-investigators driving this agenda to really push things along to say, how can we move the field forward so we can give tailored, personalized therapies to the patients? And when we think about sleep apnea, it's a chronic illness. The whole key is providing the right intervention at the right time. So we really need to help the field deliver what's considered good chronic illness care. So what does all this mean for the ASAA? As a patient advocacy association, like most patient advocacy organizations, focused on community, advocacy, research, and education. I think what we've done really, really well the last couple years is really build the community. The numbers are going through the roof. It's evidenced by the survey we did, some of our unique visitors who are visiting the website, the growth of our Awake program, increasing education to make sure folks know about sleep apnea and its treatment, and then research to help systematize all that, and from that, advocate. So this meeting is a great example of some of the work we're doing. I just want to tee up Adam for talking about all the other activities that we're doing. So I'll stop there. Thank you, and thank you to the FDA.
So you can see why Carl's a researcher and he likes to be in the back of the room quiet. Thank you, Carl. Thank you, Kim. Thank you, all our industry sponsors, the FDA stakeholders, all the healthcare and allied professionals in the room. Thank you to one of my mentors, Jills Friedman, for providing us with a slice of what about 10 patients looked like at an Awake meeting in a retired area of Daytona Beach, Florida. What makes that slice of patients interesting is that these are all retirees from around the country that have wound up in Florida. So they're not just all Florida-based. They come from all walks of life. And as you'll see today, as you saw people coming and going in and out of the room, and if you're wondering, we will keep developing the face of patient of our stories, because we wear this disease on our face. You could see us before treatment and you can see us after. And these are people that are being treated, and that's why they have smiles. The ones that aren't being treated, you can't even get them here to take a picture. Will and I showed up at our first ASA meeting about 5-6 years ago, met Mr. Gordon, and it was probably the first time 3 patients were ever at an American Sleep Apnea Association board meeting. Our eyes were blown away by what we saw and what we didn't see and what was going on in the room. And without airing all the dirty laundry, because it doesn't do you good or us good, let's just say that we've taken the bull by the horns, we bootstrapped ourselves, and where we found opportunities, we've evolved and iterated. One of those being our CPAP assistance program. Thanks to the generosity of our manufacturers, we were able to provide machines that were obsolete or gently used to about over 5,000 patients in the last few years. We were able to be an emergency resource during natural disasters with FEMA and Red Cross with that program. And we're now offering a year supply mask renewal program with that program. And when I say we're not doing this to sell, we do this as program fees and donations. We are a nonprofit. We are not a DME. And we are getting full setups in the patient's hands for 1/10 of the price in a 24-hour period. So that means if a patient comes onto our website and they fill out an application, they will get their package the next day as long as they show proof of prescription. And you heard a lot of stories today about how it takes 2, 3 weeks, 4 weeks, 6 weeks for DMEs to even get back to you. Us as a small little patient association can figure it out. I think the rest of the healthcare community can figure it out as well. We've been privileged enough to be part of what came on with the Affordable Care Act. And I know I'm the last person here, and I know you guys want to run and get out of here, and I know it's Friday. But bear with me. I don't only get to do this once. As part of the Affordable Care Act, we were privileged to be chosen to go help found what was called myapnea.org, or the Sleep Apnea Patient-Centered Outcomes Network. We learned a lot by working with an academic partner and what it's like to do research, what it's like to recruit for research, what it's like to engage for research. And as we got more self-aware and more clear, we then learned that we wanted to be in control of it. Just like any other industry in the world, you cannot design for anything without having the end user in the room. And we're not patients, we're not participants, because every one of us in here sleeps, and we have a sleep component to our lives. With that being said, we took that knowledge and that education, and when Apple came out with their Research Kit platform, we developed an app that you're all free to go download if you have an Apple phone, called Sleep Health. And it's a 2 years plus ongoing longitudinal observational study, or a pilot study, of about 11,600 patients. And we have what we think is the largest cohort of healthy sleepers and non-healthy sleepers. Now you say, well, you guys are the American Sleep Apnea Association. What are you doing with sleep health? Well, this is one disease that we don't need to spend zillions and billions of dollars on looking for a cure. We know there's an early prevention and recognition that needs to be implemented. And the fact that it hasn't is a problem in itself. Yes, everybody wants the magic pill. Yes, everybody wants the quick fix. But managing a chronic disease can be done. It has been done. And I hope my dream is to one day that my daughter is not the poster child for this or the exception, but that all children are being treated. Generations ago, tonsils and adenoids was a common thing. It is no longer, and it's my guess and my hypothesis that is a big contributing factor towards childhood obesity and ADHD right now, which I said earlier today. Our Awake program. So this was actually around before the American Sleep Apnea Association. So alert, well, and keeping energetic. Well, if you're sleep deprived and you're tired, God knows that doesn't go hand in hand with you. Even what you heard a lot of stories today about patients that are really compliant with their CPAP therapy. We're still walking through lives as zombies. The first thing I'm sure everyone in this room did today was have their coffee, have their caffeine, or some sort of stimulant. And the first thing they also did was they picked up their phone if they had it in their bedroom. So alert, well, and keeping energetic is a behavioral, so cognitive behavioral issues. It's a lifestyle, it's change, and it's something that we all have to start to do. Now with the advent of technology that we're using to broadcast and disseminate to our communities, the lights, the electricity, we have to go back to respecting the clock, the circadian clock. When the sun goes down, we need to start to power down. When it rises, that's when we need to do the work. Whether there's things in between, that's debatable as far as a couple hundred years ago, but it's just like the food analogy. If your grandparents didn't eat it, we probably shouldn't be eating it either. Thank you. So we talked about the CAP program, we talked about Awake, we talked about sleep health. We have our web assets, sleepapnea.org, Sleeptember, which is our month of awareness this September. And Sleeptember is very much about making sleep a priority in your life after summer, back to school time, back to work time, how it affects you as a family, how it affects you in the workplace, and how it affects your interaction with all of society. We invite you all to participate in it. We haven't found our viral hook like the Movember guys did with growing a beard for male mental health and male prostate health. But with that, as an example, the Movember Foundation raised about $150 million about a year or two ago. And they didn't sit on that money like the more renowned organizations that we all know of as nonprofits. They actually turned that money around and funded 80 studies. So imagine of all the researchers, all the innovators, anybody who wants to try something, imagine if they came to the end users, the patients, and said, hey, we have this great idea. We think we should use it. We could then help develop and design that with you and figure out, find that, what Carl has taught me in the research world, that RLS or that RLF, that rate limiting step. We identified countless rate limiting steps and factors today. And we are the American Sleep Apnea Association, and I can tell you we've been referred to as the Obstructive Sleep Apnea Association. Our job is to make this frictionless. It's to remove the obstructions. The PAP therapy is a stent. All it does is open up our airway. It's helping us with our breathing. We got to verify that we can measure the sleep and what's going on in the sleep stages the right way. And we have a whole litany of issues to deal with. Going back to Dr. O'Callaghan's mention of how undiagnosed, there are so many of our patients, this is not a disease, this is a syndrome. Depending upon which door that you walk through, that's the proverbial treatment route that you're going to get. You walk through the dentist, you're going to get the oral appliance. You walk through the ENT, you're most likely going to get the surgery or the allergies. You walk through the pulmonologist, you're going to get the CPAP. The cardiovascular doctors are just getting up to speed. We're privileged to have Deb McCall and Stop AFib here. We know that 80 to 90% of AFib patients have undiagnosed, untreated sleep apnea. Is that a fair estimate? So the cardiovascular community, the diabetes community, you can't manage any of these other comorbidities until you can manage the sleep or the sleep apnea, either or. So if we've done anything today is that I feel like, and what I heard from Dr. O'Callaghan and what I heard from Carl, as the professionals in the room and I as the layman, is that we all understand that we need to start looking at the whole picture. I want to thank my wife, who none of this meeting would be done without her. We felt like we just planned a wedding and we didn't know who was coming on the bride or the groom's side. I also feel like we sort of arranged the first ever engagement of the FDA with some of the internal divisions with the device and the pharma side. So we're happy to be the first disease that you chose to use to do that with. We hope to see more of that. We're all about inclusivity. There's no reason to exclude. Everyone sleeps, so at that point, there is no exclusion criteria, no matter what age. This is a cradle-to-grave syndrome, and we need to start making it a priority. It's not a soft disease. It's not Homer Simpson snoring. It's not Jackie Gleason back in the day. It's not that type of guy. This is a disease that, man, if my doctor, Dr. Gimeno, who, I wouldn't be here alive today without him, who identified pediatric sleep apnea in 1972, he literally told me if my adenoids weren't taken out at about 2 years old, my IQ would have been 70 points lower by the time I got to adolescence. And that's a scary thought. And right now, Dr. Gimeno's, a little north of 80, and I can honestly tell you, in the sleep world, I don't know who the next Dr. Gimeno is, and that scares me, especially after coming from a national sleep conference. So, and he's scared because the field is not taking it upon themselves. We need to make sleep a primary issue. It's got to be with the pediatricians. It's got to be with the family physicians. It's got to be in all aspects of life. It's not just how did you sleep, what kind of sleep, not how long do you sleep, what's the quality. That's a little bit of my soapbox. So I thank my beautiful wife. I thank my daughter, who is not here, but is home with my mother-in-law, who gets mad at me every time I ask her to open her mouth, because I'm sure a few of you heard before, we could look in your airways, and within 15 to 20 seconds, and I'll leave this with you, and hopefully you absorb it. We're looking at your Mallampati score, which is the different classes of how much airway and room you have in the back of your mouth. We're looking at scarred cheeks. We're looking at scalloped tongues, and we're looking for signs of bruxism, and we're looking for recessed chins. That's all we really need to identify sleep disorder breathing or sleep apnea. And the one other thing that really hasn't been mentioned today is we talked about mild, moderate, severe. There's a whole other classification that insurance companies don't necessarily recognize, but that's upper airways resistance syndrome, which is what a lot of the Asian population and anywhere that's where rice is the main ingredient or supplement of their diet are developing. Over the years, we have not developed our airways. We've learned to talk and communicate, so our airways have gotten smaller. Our noses are for breathing, and our mouths are for eating and talking. I'd like to thank you, because I wouldn't know where we'd be without you. So, I hope this is not the last. I hope this is the first and the beginning of many, many more important meetings, gatherings of our communities with stakeholders in an inclusive, collaborative manner, to where we can start to make a difference and start to wipe out these comorbidities in these generations, because this is not something we need to spend billions and zillions on looking for cures. This is something we know now, and we've known for 10, 20 years. And it's incumbent and it's imperative on the entire healthcare community to start preaching it. It might not be the moneymaker that everybody wants, but if we start treating this now, we are going to, the benefits for society economically are going to be immeasurable. So thank you very much for coming. Enjoy your Friday.